non-exec director nominated by Leicester University, and Edmund will tell us, give us a little bit of his background slightly later in the meeting. And Fiona Barnes, who's at her first public board meeting. Where is Fiona? Have I got her here? Yes, yes, Fiona, who's the interim director of nursing for, thank you, Fiona, the interim director of nursing for Kettering, who's been in post. Well, we were having a conversation yesterday. We couldn't decide whether it was 3 or 4 weeks, but in either case, it was quite scary, Fiona. So, so you're very welcome to your first public board meeting. Do you have any apologies or any other information, Richard?
I don't, Alan, no, thank you.
Okay, thank you very much. Can we go straight into the patient story, which is about ENT collaboration. ENT collaboration is kind of the first bit of really effective change that we've managed in clinical services as a result of the collaboration, and has been an exercise in solving what was really a very long-standing problem about how inpatients were treated in Kettering, particularly as we approach the weekend. So this is a report on how that's gone from a patient perspective. So I gather you're doing this, Fiona, and then James is picking it up. Is that right?
That's correct. And I think, thank you, Chair, recognising the clinical collaboration event that we have on Friday to discuss our clinical strategy, it's timely that we're actually going to hear a patient's journey. So if I could introduce the board to James, who's our head of patient experience and engagement. James is going to be setting the scene and talking about Bernadette's story.
Thank you very much. For those of you who haven't met, my name is James. Like Fiona said, I'm the head of patient experience and involvement here at Kettering Hospital. And with this clinical collaboration, I've been working very closely with Rachel, my counterpart at Northampton General. So if we can go on to the next slide, please. So this really is Bernadette's story about ENT services and how that's been. If we can go on to the next slide, I'll show you some more detail. So traditionally, pre the 14th of July, KGH did not offer a weekend or emergency inpatient service for ENT. And what this meant was that patients were being transferred back and forth from KGH to NGH and back again. So we engaged with our patients and looked at historical data to see where the problems lie and what they were telling us. And you'll hear from Bernadette's story, essentially, that there was an inconsistency in communication, there was inconsistencies in care. And the real thing really was that whole transfer back and forth, arriving at KGH, going to NGH, having to go back through ED to be re-triaged before going to a head and neck ward, and then coming back to Kettering General later on that week. And it really did result in a poor experience. So I'd like to share with you the video and her story, and then touch on some of the things that we've done and how we got to where we were. So if we can play the video, that'd be great. Thank you very much.
I'm Bernadette, and I've been a patient now at ENT in Kettering General Hospital for over 10 years now. And during that time, I've had all sorts of issues, but these have been long-standing since almost birth, around about 3 or 4. But I lived out of areas, you could probably hear from my accent. So I'm no stranger to ENT services, kind of right around the globe actually. And prior to coming here, I'd actually been in Germany and also Lancashire for ENT services. So different experiences, different trusts, different hospitals. But as I said, now I've been here for 10 years. Quite frustrating at the beginning in Kettering, just trying to find the right consultant. And then we came across Miss Wendy Smith, who I am very grateful to say has kept me on as her patient and is quite happy to see me in person if she's in clinic. And the team at ENT, I have got to say, as far as the wider nursing staff go, fantastic. The frustrating thing and the heartbreaking thing has been during emergencies. During emergencies, when things happen, especially over the weekend, that is a very different outlook. Then we'll arrive at Northampton General Hospital, much to the same situation, and then asked to make your own way round a maze to, and quite often at night. Why these things seem to happen at night, I've no idea, but I'm sure I'm not the first. To the Ent ward to be triaged then again, once you kind of get onto the ward. And that has been a myriad of different experiences, really. My face started to swell quite significantly, and my ear kind of radared out along with it, and obviously you kind of know that's not normal and not right. Then came the pain, and again, knowing that previously one surgery had been for quite a complicated cholesteatoma, and I'd also had very critically high blood pressure at that time, which meant I could not be operated on as quick as one would have liked, really. Admitted for several days with no change, still in pain, still swelling, till another 2 further doctors, and then eventually was transferred back to Kettering via patient transport the following week. Arrived at the ward in Kettering. Nobody had a clue really what I'd been through. They just knew I'd been transferred from Northampton. It seemed very little history had followed me. Certainly I was given no notes to bring across with me. So now I'm really actually feeling my mental health dropping now, and the tears are kicking in, the frustration is kicking in. I then saw another doctor. Again, I stress my urgency. Now I'm back on my territory. Where is my consultant? When is she in? And how can she be contacted? And I was told it wasn't necessary, that whilst there are other consultants and other registrars, they were more than capable. So you let them carry on. And I also knew and had the confidence that should somebody actually properly look at my nose, that I was in need of another scan to just see whether this was the case. Nobody would listen. When I asked that consultant why I could not go for a scan, that consultant responded to me that we are not in the habit of sending people for a scan unnecessarily. Now, whilst I appreciate that is the case, I would have thought certain pathways and certain notes would have warranted that, and it was coming across quite loudly that that had been ignored. So I allowed them to carry on with that treatment. On the way home that day, I walked home from the hospital, and I actually stopped halfway and broke down completely. Something that I have shared with very few people outside of family who actually came to get me eventually, in sheer desperation and pain and frustration. And I'm talking roadside, on the floor, just beside myself, when you're in so much pain and you need help. I came home after that and I just gave up. All of that could have been managed much better. What that left me with was, in an emergency, I would no longer go through that whole pathway. It's not the first time, and it is not the only poor story of the services across both that I have got to give, but that's the worst by far. I got the letter from ENT from the hospital trust to say that you were starting a focus group and would I potentially be interested. It's very rare that I receive any information through the post that feels so close to home, and I'm a firm believer that if nobody says anything, nothing ever changes. And sometimes it isn't about being seen as the one that's been the complainer, the whinger, the moaner, but actually people with the powers to change things are often unaware because the patient's story doesn't ever get told. And it's always looked at from a clinical perspective. This was my opportunity to put my patient story forward and hopefully make some difference as a voice, as a representative of what people do go through and how this pathway of, especially in emergencies, and toing and froing and the lack and the inconsistency is not effective, and actually how that is really affecting people at root level.
Thank you for sharing. So, really highlights some of the issues that are faced with the transfer and the back and forth between one hospital and the other. And as Bernadette has said, she received a letter inviting her to a focus group. So between Kettering and Northampton, we invited over 400 previous ENT patients that had used the emergency pathway to talk to us. From there, that's where we found Bernadette's story and her experience. And pleased to say that moving forward, Bernadette is going to be joining our working group to continue with the ENT pathway work and the follow-up reviews. Such a difficult story to listen to in terms of the back and forth and the inconsistencies, but the new process was launched in July, and that is addressing some of the issues that have been faced by Bernadette in terms of that to and fro-in. Care will be transferred to Northampton and patients will receive their care there until they are discharged home, and then they're transferred back to their home address or their place of residence. So future plans are to then follow up in 6 months' time and look at the data in total, hold another focus group with those that have been through the service to review how that has been, and ongoing monitoring of ENT services and feedback. So through our usual patient experience channels like PALS and complaints, friends and family test and compliments, what's that telling us on an ongoing basis at real time? Off the back of this, we have, with our patients, developed a patient engagement model, which we're implementing across other clinical pathway reviews, such as oncology and breast services. And that was actually shortlisted for a national award. So really positive work that's come from this. And I cannot thank Bernadette enough for taking the time to talk to us and share her story, and looking forward to working with her in the future with this clinical pathway and redesign. Any questions at all?
Okay, thank you, James. I think we'll just go straight on. I think Rabia is going to pick up now. Is that correct? You're muted, Rabia.
Sorry, thank you, Chair. And thanks, Jim, for arranging this, and thanks to Bernadette. Really heartbreaking, but very powerful story. Certainly informing how we move forward. There were lots of things in what she said. One of that obviously was for us to immediately focus on the emergency pathway, but also about the patient records. So we are, with regards to ENT itself, currently we've looked at and started our emergency pathway. So really pleased that that's from July. Is moving forward and really helping the patient. So that's great. And so it's in 3 phases now. Currently we're working on calls, but also the next phase would be the planned care for ENT patients, where we would want to offer the continuity of care, but also the consistency for all the patients. So really looking forward to James and the focus group to be helping shape the service moving forward and co-founding. So yeah, I will happily take any questions if there are.
Okay, thank you for that, Rabia. It was a very thoughtful and powerful piece from Bernadette. She'd obviously thought very carefully about it. Shortly after I started as chairman, I learned about this ENT debacle, really, that happened every weekend. And I learned about it because we had a junior doctor who had gone through the process and wasn't very happy, really. And quite rightly so. But it has taken a long time. And it does go to show how difficult it is sometimes for the NHS to behave as if there was actually an N in the title. But here we are. So it's the first bit of achievement that's made a difference to patients, really, as part of the collaboration. So any comments or questions, please? No, I'm not seeing any comments at all. Yes, Lisa.
Sorry, I've lost the hands up.
I think a few people had, actually, because I see a couple of hands now. Anyway, Lisa, and then Chris, and then Simon.
What is the actual pathway now then if you present as an emergency in ENT on the weekend?
So,
Go on, Rabia.
Thank you, Lisa. So if the patient, so ambulance will take the patient directly to Northampton is the first thing they would do. But at the same time, if a patient develops an emergency while in Kettering, then the emergency team will see them, because it may be that it's one of the inpatients, and then they get transferred to Northampton. But the ambulances take patients directly to Northampton. But there are plans in place that if patient ends up in RED, then we have got the on-call team to stabilize them, and then they get transferred.
And does NHS 111, because we're advising everybody now to phone before you turn up at an ED, does NHS 111 have clear messages that if it's ENT to go to Northampton?
Yes, absolutely on board, and that's what was in the pre-planning phase. A lot of communication and work was done on and making sure that actually patients are transferred to the right spot to start with. Yeah.
Chris, and then Mark, and then Debbie, and then Simon at the end, please. Chris.
Thank you. Lisa asked most of my questions, but it seems to me we still have what I call a swinging light emergency service. And swinging light emergency services for things like ENT always cause problems for the patient. And in my opinion, we should either provide an emergency service or not. But a swinging intermittent one is dangerous, as proven by the video, and we should consider it very carefully.
Okay, Mark, and then Debbie, and then Simon, and then we might come back to Rabia at some point on that. Mark.
Thank you, Chairman. I think my question is, as I understand, making sure the patients are in obviously the right place to receive the right treatment. The thing that struck me most in the story that I think we need to reflect on and take some action on is that the patient understood what was happening to her based on her previous experience and was trying to articulate that, and it wasn't forthcoming, or it wasn't being received as well as it should have been or could have been, perhaps, in terms of I've been here before, I understand this is a potential. The scan was a big thing for me in terms of the MRI scan, and I think as a comment more than anything, it's more something that clearly we need to go away and look at in terms of how we encourage colleagues to listen and hear the patient voice, particularly patients that are so experienced in their condition and understanding. I think that's definitely something we need to reflect on, as well as, of course, the physical location of the emergency services. But we really need, when people talk to us and explain to us what their problems may be, having experienced them before.
Debbie.
Thank you, Chair. So thank you to Bernadette, firstly, for that story. And it just shows, doesn't it, how powerful patient stories are to help us to start to make changes that we need to do for our patients and our staff, actually. Just in response to Chris, thank you for that comment, Chris. You're absolutely right. We wouldn't want a service that's swinging, so to speak. So I think just to remind the board and the public that if a patient does walk into Kettering A&E with an emergency that's ENT, of course, if they are really urgent, they will be treated there and then. If they're not, they will be transferred across to NGH. I think the point here is, if we've got an inpatient who is really quite unwell from an ENT point of view, we have got specialists on site who can deal with that sort of thing before we move them across to NGH, which clearly is the dedicated centre. But a really powerful story, and one which just shows that when we listen to patients and make changes, it's generally for the better. So thank you. Thanks, Bernadette. Thanks, Chair.
Simon.
Thanks, Alan. Firstly, just to extend my thanks to Bernadette. It reminds us that there are lots of people out there who are willing to help us improve services as patients. And as we go through the next stages of our clinical strategy, we should absolutely make sure that we benefit from their experience. The second thing I'd like to say, I think, is that there's a question for me, coming back to what you said, Alan, about have we gone far enough? You know, to what extent have we really pushed the envelope of our own comfort around this? Is this and I don't mean this disrespectfully, but is this a compromise, or have we really grasped the nettle here? I say that because we've got an opportunity on Friday, as we come together to consider our clinical strategy, to think about that question in quite a few different areas. And I think we should think about it. If we were the patient in that story, would that be enough for us? Would that be what we wanted? And we've got an opportunity not only to hear it in the context of the ENT story, but also when we consider some of the other specialties, have we really solved some of the problems that we all know bedevil acute services in Northamptonshire? And then the last thing I think I'd like to say is that I think we should keep in touch with this story. I don't think this is the end of it. I think this is a waypoint on a longer journey. And I think it would be good if the board would support saying, in 6 months' time, maybe we should go back, James, via you to Bernadette, and say, how's it now? Has it continued to develop? You know, is this feeling like what you would want it to be? Because often, you know, there's a risk when we hear these stories, we hear them and then we move on to something else. And I think this is one that, given the difficulties we've had, we should try and keep in touch with.
Okay, thank you. It's occasionally worth reminding ourselves that the whole point of the collaboration between the two hospitals to produce the University Hospitals of Northamptonshire was to improve clinical services, not to do a whole load of back office things and so on. Those were simply ways to allow clinicians to work differently. So this is the first exercise. What it teaches us, I think, is it's very difficult, surprisingly difficult, really, for people who think it ought to be simpler, including me. It's about micromanagement. It's about small issues and how they're handled between all sorts of people, and it's about breaking down barriers. So because it's the first one, it's important we get it right. So I'm sure we will agree, Simon, to go back either to Bernadette, who may or may not have been treated in the meantime, but certainly to the focus group or somebody appropriate from there. And if that is Bernadette, then that's terrific, because I thought her presentation was very thoughtful. And I think we do need to keep an eye on it. We do need to listen carefully to what Chris and Lisa have sort of said in their own slightly different ways, that we just need to be sure that this is a well understood and safe and secure service that we're offering here. Obviously, things get easier when the public are really used to using 111 before they attend to ED, but it's not always possible, and not everybody thinks like that at the moment. So we do need to just keep a very careful eye on this, and I'm sure James will through the patient group, and Rabia will as medical director. Okay, nothing else on that? Thank you very much, and if Bernadette is listening, thank you very much, Bernadette, for your contribution. It was, as I said before, very thoughtful. So, minutes of the previous meeting on the 30th of July. Are you happy that they're a fair record? Yeah, good. And there are no matters arising from it that I can see, so that's also fine. And we come to my chair's report. I don't have very much to say. The first thing is to welcome Edwin Burke, who I said earlier on was the nominee from the University of Leicester as part of our new academic strategy and our linkages in that regard. So Edmund, if you just give us a couple of minutes so the rest of the board know a little bit about you, that would be very helpful.
Thanks, Alan. I really appreciate it. And I'm delighted to be joining you all on this board. So I'm Deputy Vice Chancellor at the University of Leicester. I joined the institution about 3 years ago, just over 3 years ago, from Queen Mary at University of London, where I was Vice Principal for Science and Engineering. Before that, I spent 4 years at the University of Stirling as Deputy Principal for Research and as Senior Deputy Principal, Deputy Vice Chancellor. And before that, I spent 21 years at the University of Nottingham. I joined Nottingham in 1990 as a postdoctoral research assistant, and I left in 2011 as Dean of the Faculty of Science. I'm also President of the Operational Research Society, where in that capacity I chair the board of the society. My research lies at the interface of computer science and mathematics. We work on developing intelligent decision support engines in complex environments. So I've a number of years experience in senior management in 4 different universities and on the boards of different organizations. I'm really looking forward to working with you all, to bringing that experience to bear to serve our community. The partnership with the universities, I think, is really important, and it's critical that we saw that really compelling story from Bernadette, and I think it's critical that we bring our experience together to ensure that the community gets the very, very best service that it can, and that in future, when we hear from patients like Bernadette, we hear a really positive story. That's what I would really want to contribute to this board. And as I said before, I repeat myself, it's worth repeating it. I'm looking forward to working with you. I'm looking forward to doing all that I can, all that we can, to improve the services for our community.
Okay, thank you very much, Edmund. That's very helpful, and I'm sure we'll find a way to involve you in many ways in the running of the board with that background of expertise, and particularly the linkages into the education system in Leicester. The only other thing I wanted to say was the recruitment of the chief exec into the ICS. You know that the ICS chair was appointed, Naomi Eisenstadt. The process nationally for appointments of ICS chief execs is going forward. We have a shortlisting next week, and we have the interviews towards the end of October. So hopefully we will be able then to start the process quite quickly of taking forward the creation of an ICS board. And I'll talk briefly in the private bit this afternoon about the recruitment of non-exec directors to the ICS board. And we'll just come back to that at that point. I don't have anything else. Simon.
Thanks, Alan. So I'd like to start by just noting a different group of people who serve our hospital and thanking them for the work that they do. Last week it was Organ Donation Week, and we're fortunate in Kettering. We have a hugely active group of volunteers who come and do great work in that space, and I was privileged to go and meet them. And I was reminded about how our lives intersect in so many ways. One of the volunteers was telling me the story of her daughter, who sadly died in Kettering 4 years ago, and how she came to be part of the organ donation team, and how just in this last week, she'd had the opportunity to meet the young man whose life had been completely changed by the donation that her daughter had managed to give. And it was an incredibly moving story, and she told me entirely, just candidly and openly, and I just wanted to reminded me, I think, to acknowledge their contribution and the service that they provide to the hospital. And I didn't know, but I wanted to share with you all that the theme of their campaign, as I say in my report, is leave them certain. And it reminds us of the fact that still too many conversations don't happen about what our intentions are. And so I would encourage people, either listening or through their good offices, to promote the work of the team, and wanted to thank them here. Broader news, so nationally, it will not have escaped anybody's notice that the NHS has been in receipt of a lot of money. The important thing over the next period of time, as we run through October and November, is to make sense of what that money can deliver and what we are expected to deliver for it. And I highlight kind of the two challenges that I think we will be debating. As we speak right now, the H2 planning guidance hasn't yet been issued, but doubtless we will be coming back to it in future board and committee meetings. But the challenges that are in principle posed by it are clear. So nationally, we find ourselves in a position where the waiting lists have hit an all-time high. And that clearly is something that we are expected as a national health service to grapple with. And I think within that, there are three now concerns. So the first is we find ourselves in a position where nationally we've got people now waiting over 104 weeks for surgery again. I had thought that we had eliminated that during my career in the NHS. It's where I started out with weights like that. And now I find myself in the place where we are that again. We're fortunate in Northamptonshire that we don't have those problems. And I want to immediately pay tribute here to the teams in the hospital who've done a stellar job in keeping surgery going throughout the period of the pandemic. We are not in the place that other areas are. But I do need to signal that as we are, as Alan rightly said, a national health service, the ask may come from us to help out other areas who are not in as fortunate a position as we are. And I think that ask, I have to say, is right, because if we are in a position where some areas cannot recover the waiting list challenge, we are in the original definition of a postcode lottery if we do not stand up and start to help in whatever way we can. The other two challenges are the maintenance of the cancer standard. We know that during the pandemic, two things happened. People stopped coming for treatment, and so referrals dried up. And secondly, treatment that was on the books slowed down. We need to make sure that we keep a grip on that. And then thirdly, nationally, the challenge is really not to let the waiting list problem grow any further. As demand recalibrates towards pre-pandemic levels, we can expect demand to increase over time, and it's incredibly important that we do our part to address that problem. So that's why I'm particularly pleased, I suppose, that the board today will start to have a conversation in public about theatre efficiency. And although that's not something we've commonly talked about previously, it is really important that we are publicly accountable for how well we are doing with some of our most expensive real estate and some of the most complicated things that we do. So it's the opening of a debate today, and I look forward to that discussion. In parallel with that service challenge, there is inevitably a money challenge. The amount of money that's coming to the NHS is significant. £1 in every 3 of taxpayers' money now comes to the NHS. But equally, the costs associated with running the NHS are rising quite significantly. We've got pay award issues to deal with. We've got efficiencies to deliver. So it's not as neat as saying all of that extra money buys free additional activity. We've got a complex series of issues to balance in that space. There will be ring-fence money for electives, as again, I speak right now, the programme around that isn't clear, but it will be something that we need to balance and explain to our public how we are going to respond to whatever settlement eventually is published, hopefully this week. The related financial challenge, I think, really comes back to the point that Alan was making about the ICS. It's very easy to get obsessed by a particular period of NHS time. But the bigger challenge that I want to draw the board's attention to, which I think does need to occupy quite a lot of our time, is rather than thinking about the next 6 months, how do we get Northamptonshire to a place where it can balance itself over a period of time, to be determined and agreed? But that, I think, is going to be a much more fundamental challenge, and one that we rightly should give our attention to in these discussions. The majority of the financial challenge in Northamptonshire, as we sit here today, sits with the acute hospitals. That's the reality of it. Now, some of that's in our gift, some of it absolutely is not. And we need to be having those conversations with system partners as we form the ICS, in order that we can really start to move towards what that sustainable financial strategy is. Last thing to say today, two last things. It would be remiss of me not firstly to comment on the fact that Leanne left us last week, our Director of Nursing. We had a series of very good goodbyes, and Leanne's one of those people who spent a lifetime in the NHS, 37 years of service to the NHS, and has made a huge and lasting difference to nursing in Kettering. As I say in my report, it's difficult to compress into words 37 years of service to the NHS, other than to say she has made the most enormous contribution, and we should all be profoundly grateful for that. And if she's listening, I think she may have gone to France this week as part of her post-retirement plans, but if she happens to be listening, Leanne, we thank you and we wish you all incredibly well. We're lucky to welcome Fiona into the role. Somebody of her experience and calibre in our system, again, is a product of the group working that we're able to now express. Finally, last week I opened the Tree of Hope. My goodness, if you haven't had a chance to see it yet in the atrium, I would thoroughly encourage you to do so. It's quite the most impactful installation. I think is probably the only word that I can adequately use for it that I've seen in a long time. And I put down a little bit what it means to me, but as with all art, I think it's worth going to see and seeing what and reflecting what it might mean to you. It was certainly very powerful and moving for me. Thanks very much.
Okay, thank you. Pause there. Any questions or comments about what Simon has said? Some of the stuff will obviously come up later on as we talk about money and winter and various other things, but any immediate questions on anything he's raised there? Nope, not seeing anything. Debbie, over to you.
Thank you, Chair. So I'm going to start today with an update following the national blood tube shortage, which I'm sure many of you will have read about in the press. So all primary care and community care providers were asked to cease non-emergency, non-urgent testing, and acute providers were asked to reduce demand by 25%. We, from a KGH point of view, led the system response, and I'm really pleased to say that the overall demand was reduced by 55%. Now, since writing my report, the supply is back to almost normal levels. All primary care providers have now returned to normal levels of testing. They have got a small backlog which they're trying to manage, but it's tiny. However, acute trusts are still being asked to work at reduced levels. So we are expecting some further guidance on the 8th of October. We have around about 5 days stock at any one time. And again, really pleased to say that we've had no harm noted or no complaints either due to the reduced demand. So a brief update on the blood bottles. It would of course be remiss of me not to mention COVID. So today we have got 34 inpatients who are COVID positive. 5 of those are being cared for in our critical care area. Over the last week, you will have seen in the press actually that case rates in the community have increased, and especially in Kettering. Although this time the conversion rate to admission appears really quite low. The majority of cases are now in the child, younger adult age range. What has started to increase though is our non-elective activity, as you would imagine. And throughout the summer, some days have been as busy as we would have seen previously midwinter. And this has put quite a lot of pressure on our staff and some of our services. And earlier this month, we had to open our winter ward as an escalation area. So we'll talk a little bit more about that as we go through the rest of the agenda today, as we talk through winter and current activity. Winter pressure this year is expected to be significant. Our internal winter plan is really well developed, and Faye will be able to talk us through that later. To complement that, there's also a system-wide winter plan in place, and the majority of that plan is has started, but I think it's probably fair at this point to say it's quite dependent on recruitment across our system colleagues, and that's recruitment to new and existing posts. And that's, as we all know, is a real challenge across the whole health and social care sectors at the moment. Throughout the last couple of months, we have celebrated an awful lot of achievements in the hospital, which has been really good to see. Some of those are noted in my report, but there are 2 for me which really stand out. The first one is that we're the first hospital in the UK to adopt a new imaging and biopsy system. And this will ensure that our patients with suspected breast cancer can have the biopsies in a much simpler procedure at Kettering, instead of having different and several different appointments at different hospitals up and down the country. So that's really good. I'm really pleased that that's happening, and it's put us on the map. So that's great for our patients. The second is something which our HR director led on, and this is the outdoor gym. Now, this might seem like it's a small thing, but actually, we purchased this with monies from NHS Charities Together and the Sir Tom Moore Fund. The reason that I wanted to mention this achievement really is because it's a really good example of something that our staff have asked for, and we've been able to work together with the charity to make it happen. I haven't had the opportunity to use it yet, but I have heard that people are talking about it an awful lot, how good it is. And I believe that when it's good weather, it gets really quite busy. So I would also just like to finish by informing the board about something slightly different, which is last week we had a site inspection from our local fire and rescue service. The verbal feedback which I've received is that the inspection was a positive one and no concerns were raised. So again, just ending on some good news there. I'll stop there and take questions, Chair. Thank you.
Okay, thank you very much, Debbie. Anything anybody wants to pick up from that isn't obviously somewhere else on the agenda? I think that I'm kind of guessing that's Trevor's hand. Trevor, yes, Trevor.
Yes, it's trouble reaching across. Thank you, Debbie. I think one of the other areas that some of our colleagues might like to hear about is whether or not we've had any concerns about staff accessing work because of the fuel problems that have been around.
Yeah, thank you, Trevor. Really good point, actually. So no, we haven't had any issues so far. And in fact, I understand that there is a local petrol station who is also allowing priority for some of our staff if they go there. That's been noted on our social pages within Facebook. But no, nothing significant, no complaints. Staff are managing well to get into work.
Okay, anything else at all? No. Okay, integrated governance report. Debbie, you're going to compare this entire section and get us through to the break by about 11:30, after we've also talked about the IGR metrics. So that's a clue to everybody about the fact that this is not an advert for what committees do. This is an exercise in what do you wish to escalate to the board. So over to you, Debbie.
Thank you, Chair. I will do my best. So it's been an extremely busy couple of months since our last board meeting. And as already noted, COVID aside, the summer period really hasn't allowed for any downtime for our staff. The bed occupancy in the hospital has remained really quite high. As I noted, escalation beds open. And on most days, we haven't just got the winter ward open, we've got other areas open with inpatients as well. We've been on Opal 4 throughout quite a lot of August, which again is very different than previous summers. And that's put pressure on our staff and on our services. I would just like to mention that unfortunately we have had a Never event that's currently being investigated. However, I do understand that no harm was caused, and we have plans in place to hold a learning event from the Never events that have taken place over the last 12 months. That event will take place in November, and I'm sure that Chris, our Quality Committee Chair, Medical Director and Director of Nursing will want to comment on that as we go through the IGR. While some of our performance metrics have deteriorated, we are working hard to recover these. But what I would like the board to just note is that our performance compared to other hospitals in the region remains extremely good, and especially for cancer 62 days, where we're actually in the top 3 trusts in the region. And also RTT, 52-week waits, we remain one of the best performers nationally on this metric. So I'm now going to hand over to the committee chairs and the executives to provide an overview of just the salient items, please. And I'm going to start with our Quality and Safety Committee and Chris, please.
Thank you very much. Very quickly, I wanted to mention 3 annual reports that we'd received: fire safety, end of life and learning from deaths, and I would commend them all to the board. Particularly learning from deaths is a really superb piece of work of which Kettering should be very proud. We also noted the infection prevention and control BAF, and that there were 2 areas, 2 gaps in the assurance that is necessary, but we recognised that the mitigations that had been put in place were appropriate. The one thing we did spend a considerable time to discussing was the issue of staff availability. And we understood at the committee that staff availability reduces from 100% or running about 90% in usual times down to 60%. So 40% of the staff unavailable. If you take that with the bed occupancy of 100% or more, together with the increase in non-elective activity, this significantly increases the potential for risks to both patients and to other staff. And we had one example of that in which there was an outbreak of COVID on a ward, which possibly, and it's still under investigation, was linked to the fact that a day 6 swab was not taken, and that probably was due to staff non-availability. So we discussed privately a process for staff to return to work after contact with someone with COVID, and that has been put into operation as a group protocol in the last few days. And I look forward to hearing how that's working. I've personally been through the paperwork that attaches to that, and it touches all the necessary bases and covers particularly allowing people to work in low risk areas. So that's the end of the Quality and Safety Committee report.
Thank you, Chris. Rabia, is there anything that you would like to add?
Thank you, Debbie. Thank you, Chris. Totally agree with Chris on learning from death, and it's later on in the agenda. Dr. Natarajan is presenting, so I won't say anything at this stage for that. All I just wanted to add, Debbie, you mentioned already about the never event learning and reflection session we are holding later on in November, looking at all the never events for past 5 years, actually, including the one which has happened in this year. So just wanted to stress that. Thank you.
Thank you, Rabia. Fiona, is there anything you'd like to add?
Thank you, Debbie. As Chris mentioned, we had a very detailed discussion in regards to how the staffing or the unavailability of staff can affect the quality of care that we provide as an organisation. And we were able to discuss with Chris and those members how we mitigate the risk in regards to patient harm. And it's important to identify that this was also discussed as part of the People Committee. And it is also a key to mention that as part of that discussion, no harm has come to patients due to a shortage of staff because of the extensive mitigation that we have put in place and do so on a daily basis when we review our staffing levels across the organisation. Thank you, Debbie.
Thanks, Fiona, and thanks, Chris, for raising the risk assessment process that we have put in for those staff who are isolating due to household contact with COVID. I think that's a really good thing for the group to have in place so that we are treating our staff in exactly the same way in terms of either staying at home or returning to work. So we'll move on now to Damien to do finance, performance and resource, please. If you can just hold off on questions until we get to the end, as we may be able to answer them as some of those questions as we go through. Damien.
Thanks, Debbie. Good morning, everyone. So just a few quick things to bring to the board's attention from Performance, Finance and Resources Committee. The first thing I just wanted to reiterate what Debbie said around many of the performance measures like RTT, cancer and so on. The trust is holding up very, very well against and has done for some months now, and that's not just from a KGH perspective, it also holds up when we look at the performance of the trust from a national benchmark perspective. There's probably two things, one in operational performance to raise to the board's attention. The first thing is that super-stranded and stranded patients have gone up quite significantly month on month, and when compared to the year-on-year numbers, super-stranded at 90 and stranded at 257. I raise that as it will have implications for the winter modelling, which I think we will look at under agenda item 7 if that's not dealt with. And we discussed this at length within the committee, and I think there was a assurance that there's a high degree of focus on alleviating that problem, but also it was made clear that it's not totally within KGH's gift to resolve that. We do require system partners to help create the capacity within the overall healthcare system to be able to discharge some of those patients, but there is certainly a high degree of focus on that. The second thing I wanted to raise, which I think John will talk about later in the agenda from the finance perspective, is that KGH is running a year-to-date deficit in month 5 of £5 million. That is a 4.1 million adverse variance to where we thought we would be at this point in time. There are various factors that have contributed to that situation. We are, as a committee, continuing to unpackage that in collaboration with John and Danielle on the finance team. I think suffice to say there's probably more work to do on that in order to determine how we plot a future course through that. They're probably the two key things that I would raise.
Thank you, Damien. John, is there anything that you'd want to raise at this point, please?
Yeah, just to add a little bit more kind of meat to the bones on that position. So for board members, that scale of movement, certainly the 5 million deficit, I chunk that into kind of two halves. Kind of 2.5 million of that are things that have been as a result of changing conditions. So how we would earn money from elective recovery point of view has changed since the plan was set. That was a national decision, and we have a significant pressure around the cost of non-PBR drugs of about 1.3 million to date, because we are treating more patients across cancer and medical specialties. That treating more patients is a very good thing. There are cost implications. Previously, those drugs would have been reimbursed to us at cost and not caused a financial pressure when we were operating in an activity times price model. As you'll be aware, we are operating under a block contract model, and therefore any additional costs incurred there is creating a financial pressure to the bottom line. The other balance, the kind of other half of the 5 million, as Damien has quite rightly said, we are unpacking. It's a combination of kind of operational challenges. We're spending more in theatres, again, because we're delivering more activity than we had planned to do. That's around £1 million. And we have put some targeted investment to manage some of our areas of pressure, like international nurse recruitment, hospital discharges, enhanced care, etc., all of which are the kind of manifestation of those operational problems that you've seen. So I'm comfortable that we have a narrative. As Damien has said, we've worked through the drivers of that. We've got further work to do about what that means leading into the second half of this financial year, but that's absolutely a focus of effort as we move forward.
Thanks, John. Faye, is there anything that you'd like to add on the performance side?
Thank you, Debbie. Just to give the board a flavour of some of the things that we are trying to do internally to tackle our super stranded and stranded position. So this week we have Give It a Go week. This is a system-wide initiative that we are doing, and basically it just gives the teams an opportunity to say, what could we do differently that might have an impact? And the feedback so far this week is really, really positive. So we're really having a look to see what else we can do. We're also working with NHSEI colleagues to look at our discharge processes on the wards. We've got 5 pilot wards. It's an 8-week programme, and we're hoping once the outputs of those programmes of work have been completed, that we'll be able to roll that across the organisation. The teams are really excited about it. The wards have put themselves forward for this project, so we're really hoping that this will help some of our discharge processes and help us reduce some of our long lengths of stay for our patients. I think, as we've said, clearly we do need support from our social care partners. They are experiencing significant problems with their recruitment, particularly for patients that want to go back into their own homes and be cared for. But we're working really closely with them on some initiatives to see how we might support their recruitment processes. So I'll pause there. Thank you, Debbie.
Thanks, Faye, and we'll pick some of that up under the winter discussion also. So if we can move now to our People Committee, and Janet, please.
Thank you. Basically, the really good news we've got from the committee is the medical education has been subject to an assessment by the General Medical Council. We came out as the joint best in our region, a really significant piece of work given the current situation with regard to staffing. We've looked at the plans for nursing and midwifery and agreed that that was a really positive way to go forward. We reviewed the Equality, Diversity, Inclusion strategy, which the board approved at its last meeting, noted progress on that. I think the key thing that we need to recognise was around the risks around the people absences and recruitment, and the committee asked for further information and deep dive with regard to that. I think at that point I'll pause and move back to you, Debbie.
Thank you, Janet. Mark, is there anything that you'd like to add at this point?
Just one or two bits, Debbie, just to make the board aware of some additional strategic risks for us. So one is in regards to the mandatory COVID vaccination. You see the government are consulting about this at the moment for NHS staff. That closes in October. And that's something that we're obviously keeping an eye on and making sure that we have plans in place should that come into fruition. The second element is with regards to the pay award. So the pay award was provided and has been given to colleagues in September's pay. However, there is uncertainty and the potential for industrial action in and around this in the coming months that the trade unions are balloting members upon. Again, it's uncertain. We don't know when, we don't know the results of those ballots yet, and we don't know what type of industrial action, but it's something that we're definitely keeping an eye on. And lastly, as we move into October, it's Black History Month. So we'll be putting out a number of events over the next couple of weeks to celebrate Black History Month. Is it worth also, I saw Lee's in the chat around winter vaccination. So we talked about that at the committee. And yes, very pleased to say that on Monday, we start our winter vaccination program, which is both COVID and flu vaccinations. And we've got over 4,500 appointments that we're able to offer for staff between 7 a.m. and 1 p.m. Monday to Friday, and weekend clinics too. Hope that's helpful.
Lovely, thank you, Mark. So let's move to audits now, please, if that's okay. Trevor?
Thank you, Debbie. Yes, audits. So 3 points arising from the audit committee. The first, and not the order in the report, but the first one was that we approved the external auditors report on the final element, and that was delayed. And so we're in a slightly different place. So the bit that's not here was the fact that that then meant that the annual report could then be placed before Parliament, because the delay in the process around the audit report caused by national changes, not our local issues, national changes in terms of the amount of work the auditors had to do, caused this to be a delayed process. So that has now been laid before Parliament, which means that it can be shared. Very good news on the medical records. We heard from Richard Apps about the work that's been done to reduce the measurement in inches of the amount of outstanding medical records that had yet to be filed. And this has been an issue that we've been following for a long time, since internal audit reported on it a couple of years ago. So that was extremely good news, but we will still keep our eye on this one because it's one of those problematic ones. But the digitalisation of these records should move the issue out of the way completely in the near future. Thank you.
Thanks, Trevor. And yeah, that's a key part of our digital strategy, isn't it? John, and then Richard, anything that you would like to add, please?
Thanks, Debbie. It's probably worth me raising, I should really raise to the board around some of the recommendations that our external auditors raised in their annual report, one specifically around a significant risk to financial sustainability. So it won't be a surprise, it's been discussed already today around the lack of clarity on our financial regime moving forward. Our auditors, not the same as other audit firms, I must add, took a view that due to our historic underlying deficit and the lack of certainty around financial regime, that meant that there was a significant risk to financial sustainability. I don't necessarily support that view. And I know that wasn't a view that's been taken by other audit firms. However, I am comfortable that the view that was taken by Grant Thornton was consistent across the firms that they support. And in the absence of any clarity moving forward, or much clarity moving forward around details, I can understand how they reached that conclusion. As well as that risk, we provided the management response to that. The management response was acknowledged and accepted at the audit committee, and we have a number of pieces of work in train around how we manage and support system level financial sustainability over the coming months, and also work on our group level governance arrangements, again, which is work in progress and work in train. I should probably also add that there were no concerns raised in the standard reports from internal audit or anti-crime. For those who don't know what anti-crime is, it's a new name for counter fraud. So no concerns raised by either of those bodies.
Thank you, John. Richard, anything else to add?
Thank you, Debbie. Just a couple of things very briefly. First of all, on the annual report, again, huge thank you to Richard May for collating that document and getting it submitted before Parliament. And a note for diaries, members should have received an invitation for the 3rd of November annual members meeting, where the annual report will be presented. And then on the loose leaf filing item that Trevor mentioned, just to assure the board that that is not a question of case closed. The operational management group have been tasked with keeping this firmly on their radar, and they receive regular reports on progress across all divisions. Thank you.
Thanks, Richard. Yeah, and just to add to that, via the performance meetings with each division, it's noted there also with actions. Thank you. Okay, so I think we are now going to digital, and Alice, please.
Thank you, Debbie. Yes, just a couple of quick things to update on from the Digital Committee. Firstly, we conducted a deep dive into the cybersecurity risk for the organisation, well, actually across the group, and the committee was assured of the work going on in that area. It's something that we've been considering for some time and has been on the agenda, so it was good to get some additional assurance on that. And we also received an update on the cloud first implementation, which is good news for us as an organisation because it gives us additional resilience and frees up our people from doing the on-site work to doing more interesting things that we want them to do in connection with our moving forward digital strategy. So we were assured that we're on track on that piece of work as well, and that has now been adopted by our colleagues at Northampton as well. So they are on very much the same journey. We received an update on the Northants shared care record. Unfortunately, we've got a slight delay with that, with our Kettering input to that, but we hope we have a plan to get that back on track. And then I think finally the most significant issue that I know the board have been updated about separately is the health intelligence team. We have lost some key personnel within that team, and there is a continual relentless demand for information from that team, not just driven by COVID, but by a number of factors. And I know has been updated to the board, we've put in place, Andy and the team have put in place a so-called fire break at the moment to give that team some time and space to put in place some of the enhancements they need so that they can keep pace with demand. And thank you to all board members who have supported that going in place. We're aware that that means some sacrifices in terms of what we can produce in the short term, but we hope that that will give a long-term benefit. I think that's all, Debbie, from me.
Thank you, Alice. Andy, is there anything you'd like to add, please?
Just two small things, Debbie. Yeah, so just picking up on the health intelligence, this week the advert will go out for a group head of health intelligence, just picking up on that situation. And then we've talked about the scanning of records, and just wanted to update to colleagues that of the inpatients discharged, 25% of those have their full historical medical record now scanned. So part of our progression to move into be removing those historical paper records.
Thanks, Andy. That's good news. So I think we're back with you, Alice, now for Collaboration Programme Committee, please.
I think we are indeed. Yes, the meeting this month, following a gap from the meetings in August, we caught up on the clinical collaboration piece, which we've talked about earlier, particularly with ENT, for example. And moving on from that, we approved the agenda and planned for the conference that we have on Friday. Apologies, I think there's a typo in my report saying it's the 2nd of October. It is obviously the 1st of October on Friday, for anyone who spotted that. And we look forward to that. And we talked very much as well at that committee about what we're asking of our clinicians at that point, and the balance between what we as people, if you like, behind the scenes, not on the front line necessarily, have to do in terms of what we need to put in place, and what in return we ask our clinicians to bring to the table, and how we position that on Friday. So I'm really excited about being at the event on Friday, and I know a number of us are there to really start to move things forwards again on that front. So we spent quite a bit of the meeting talking about that. We also spent quite a bit of time, as I know a number of the other committees have done, in thinking about kicking off the IGR at a group level, the Integrated Governance Report at a group level, and really focusing down on what those metrics should be. And also at CPC, really what feels like a comfortable level of metrics that the board can look at all together. Inevitably, it's going to be to some extent a bottom up and to some extent a top down process. And we started talking about what that level started to feel like, and acknowledged all the hard work that had gone in to date, and the benchmarking information, which was really useful in bringing together that. And then finally, we spent some time, Mark updated us on the progress so far on implementing the group people strategy. And there was some challenging debate there around what we were doing in the people strategy that was really making a difference so far, and how we were going to really measure that going forwards.
Thank you, Alice. Simon, is there anything that you'd like to add, please?
No, I think we should get on to the debate about the IGR metrics, given that hugely comprehensive update by Alice.
Okay, thank you. So one final committee, which is the Strategic Development Committee, and Alan, please.
Always nice not to be forgotten, Debbie. Thank you very much. I have only a little thing to say. We've moved into a relatively stable bit of the process, really. Although the big issue remains the bringing together of the two pots of money that we've been allocated. And unless that process is concluded satisfactorily, it will make life very difficult about how we go forward. So I'd just like to thank our local MP, Philip Hollowbone, for persistently raising this issue in Parliament and indeed with ministers, Secretary of State. And I know Simon has been in a meeting there, just pressing the case for what to us seems like a remarkably logical solution to the problem. So we're hopeful that that will move forward satisfactorily in the next little period, which will allow us to make the build programme more rational. The only other thing to add to that is I think it's now appropriate, and I've agreed with Polly, that we will move to less frequent meetings. We'll have them every second month as we go through this relatively stable period where the exec can take it forward. And if we're genuinely going to be a strategic development committee, we should stick it being strategic. So we'll be doing it every second month, and that plays out into the plans for a group, a strategic development committee as well, which will take a rather higher level view of the problems. Thank you.
Thank you, Chair. Polly, is there anything you'd like to add?
A couple of updates, just to alongside what the Chair has said. So we are continuing positively with working with the national team with our enabling works and key. So that's about clearing the site and making it ready for our first build. And key part of that is our new energy centre and new energy infrastructure across the site. So that's progressing well. That will mitigate against one of our key organisational risks, which is our ageing steam infrastructure in the site, and also it will be a very key first step on our journey to becoming net zero carbon, which is obviously very important. So that work is ongoing, and future board meetings will start to also see some of the outlined business case development coming forward, in particular reviewing our shortlist of options and going forward to our preferred one, much as we did with our strategic outline case. But that's it. Thank you, Debbie.
Thank you, Polly. So before I move to Andy, are there any questions on this month's IGR, please? No, can't see any hands up. So, okay, thank you. Thanks, Chair.
Okay, thank you, Debbie. IGR metrics. It's important to think about this in the kind of hackneyed phrase that less is more here. Boards are meant to be able to focus on the things that matter. And when they're dragged into detail or routinely presented with detail, it doesn't help. It's not good for the board to be presented with long reports, which are difficult to read, difficult to understand, and don't actually distill the essence of what it is we're talking about. So we have been pressing, I have been pressing, as you know, across the group for some time, and this is part of the governance review that we've kicked off around how best to use non-exec director and board time, and then into the organisation, how best to use exec director and other leaders' time to manage the group in a well-led way. So we're talking here about the group IGR metrics. We should remember this is a cascade. Committees can have more metrics, and indeed the operational processes will have many, many more issues that they look at and review on a routine daily basis, depending on where in the organisation you are. And I think we should also remember to think about it in terms of the introduction of Power BI, which will allow people to drill down to any level they wish to. Now, some non-execs will be familiar with that as a product, some will be familiar with something similar to it. And obviously in due course, there will be some training programs run to allow people to look at the level of detail they wish. But I start from the proposition here that we ought to be aiming for around about 40, 45 metrics coming to the board on a routine basis, on which it is the business of committees to decide what those are, They can change them from time to time, obviously, and there will be times when something happens which requires all that to be superseded. But in general, we look to focus the board on the things that, if you look at those 45 metrics, then the board can be comfortable that they know how the hospital is running and working. There's always opportunities, as you've just seen, for committee chairs and others to raise things directly. So this is an exercise which we kicked off in the July board, July board, about bringing this together in a single group set of metrics that allows efficient governance to happen across committees in common, and is an exercise that is going to go on over a period of time. And we did originally set the challenge of getting it sorted for this meeting, but that's been moved back a bit. And actually, I don't think we should be too demanding of when it's done, give or take a month or two. And nor do I think it should be perfect. We shouldn't allow the perfect to drive out the desirable in this. This is a bit of a suck it and see exercise. So, Andy, I think you're presenting where we are on this, but that's the context for this. And we need to avoid the temptation of thinking that every item we worry about should become an item for board reporting. We have highly effective committees. And the way to do this is to make sure there is a proper pyramid of data being presented at the relevant levels in the organisation. Andy.
Thank you, Alan. A really great introduction on this topic, and we've had some really good discussions in the committees in the last couple of weeks about the different metrics, and it's starting to take shape of the different metrics that folks want to see at a committee level and then into board level. That's not to say it's not been without its difficulties, and as you've hinted at, it's really hard to make a decision about which ones to go forward. And I think it's worth saying, actually, if you look to some of our neighbours and what they have in some of their reports, you'll see that they equally have a challenge. You look across and see a variety of things at UHL, Oxford, and others, and see that very much there isn't, if you like, a national standard for this. So we've got to plot our own course and determine which of the things that are important to us. So in the report, you'll see a timeline for continuing that committee engagement. There's the audit committee to have the discussion with, and then what I'll be doing is sharing out a first proposal on the back of the committee discussions for what things go to what committee and what comes to board. We can then iterate that through the CPC meeting and then work that into actual, a deliverable report. So that's the update. This is it's not as easy as I initially naively expected, but there's been some really great discussions, and thanks for colleagues for all your contribution.
Is there anything you want from the board today, Andy, to take this forward? Or are you happy that it's got its mechanisms working through committees?
So always take feedback from colleagues. Committees have been tasked to come back to me with their thoughts if we weren't able to come to a view in the session. But yeah, always welcome some thoughts. The slide that's most relevant has got the list on it, which is slide 10, I think it is. Yeah.
10, yeah, 9, 10, yeah. Okay. Any comments at all on that, Chris?
Thank you, Alan. Really good paper and really good work going on. But just for the benefit of NEDs who are not living and breathing the temperature, pulse and respiration of KGH on an hour-by-hour basis, I think it would be helpful if we had some high-level sort of headline reports. What's the bed occupancy? What's the staff availability? ED attendance, ambulance handover, that sort of thing, so that we know what it's like. But being told we were on, it maybe the headline is Opal 4 for the last 3 weeks is the answer, but it's something along those lines. And then we get into the detail behind it.
Okay, anybody else got a comment that they want to just throw into the mix here? I think this, I keep saying this is a bit of a suck it and see exercise. It does require a lot of thought to go into it because we're not going to randomly go into it, but it is a bit of experiment as we go along. Trevor?
No, I experiment as we go along. And I think one thing that I'm concerned about is that we are open to change, that, you know, this becomes something that we're able to use. And if something comes up that we need to add to the list, we add it to the list, but we also then take things away as well, so that we don't overburden the list, because that's the tendency, is for these things to grow and grow. So whatever number we take, whether it's a random number or we can put some science behind it, we have a limited number of metrics. I totally agree with Chris's idea though, because just seeing we're on Opal 2, 3 or 4 actually doesn't tell the whole story. And whilst we won't get the whole story, we do need something slightly more than just those Opal numbers. Thank you.
Sorry, Simon.
Thanks. 3 points for me. On the let not the best be the enemy of the good, I think we need to progress this conversation to a conclusion for the November cycle, so we stop. There's always an opportunity to refine and improve. On the points that Chris and others I think were making, the conversation that I think we need to have is, I think boards need to focus on strategic long-term indicators. So my question would be, what are those, the ones that we keep coming back to? Because there are some underlying issues that we probably need to pay more attention to here. And there's a version of your challenge, Alan, where we maybe decompensate from the board into committees, where committees end up looking at a lot more metrics. So I think the discipline that you're asking us to apply here needs to equally extend to committees. And just to put one of the kind of longer term indicators, I think on the table where I think we would need to pick up on it would be some of the data coming from our new People Pulse survey. If we're about our people, that's an incredibly rich source of information. How do we choose and prioritise those indicators? So I think strategic long-term indicators for the board, but there's that challenge for committees too, not to over-egg it. And then the final thing, of course, which I think is the thing that really the IGR will really need to think about, is it's all very well, even if we can agree the indicators, let's assume that we do. The skill is, of course, in drawing the interpretation and saying, overall, what we want to say as a board is this, as a result of bringing those key indicators together, whatever they may be, because that's the skill that we need to bring to our table. It's the interpretation. And I think I would encourage people to think as much about how do we want to interpret the metric, and particularly the relationship between them. And I think we've agreed that we'll come back via CPC in its next cycle. So by the time the board sees this in November, we will have had not only a further go through committees, we'll have also had another opportunity, what I think was a very good debate at CPC a week ago last Monday, to test some of the thinking that is coming out of that. Thanks.
Thank you, Simon. Yeah, I mean, I think the advantage of fewer key metrics is that we can expect an improvement in the quality of the narrative around the SPCs, which will allow that to be understood better. But I also think we ought to bear in mind that we ought to have in there the things the board are intent on changing the metrics on, those things that we think are crucial to improving our efficiency and functioning. For instance, stranded and super stranded is an area that you'd be looking to make a change to, because persistently showing us random variation SPCs is probably not that productive. Lisa.
Yeah, thank you, Alan. Entirely agree that we need a strategic set of metrics, but I think the board also needs to have the assurance that if there are specific issues with specific specialties, that those get flagged as well. Because it would be very easy to just think everything is going on okay, when unbeknownst there might be one specialty, ENT, orthopedics, I don't know, that have particular issues at that point. So I do think we need to balance it with the board briefing, and that relies on the exec to tell us when there are specific issues.
Yes, I couldn't agree more with that. I think the responsibility for committee chairs to choose to raise something specifically with the board is going to increase, if you like, but it's always there. but that follows through that the responsibility of the exec directors to make sure the committee understands those issues. And they step outside the routine metrics because of an event, whether that be a never event or a particular staffing problem or a particular failure or whatever in the committee. So I think the responsibility down the system to exec directors and to through committee chairs to make sure that they are actually engaged in this in an open and transparent manner is crucial to how it will work. And if we are going to make the group work as a governance vehicle, then the openness and transparency and the Power BI information packs that allow you to go down to look at what you want to look at become crucially important. So I suppose the point of that is it's a package. It's not a simple IT problem to solve, thank you, Andy, but it is a package of behaviour and thinking that comes together to make this a better governance model for the group. And I do think it is extremely difficult to get right. You know, I know the Joint Performance and Finance Committee didn't go all that well this month for a variety of reasons. I know that some other committees think differently about whether they do things when they do it separately and when they work together. So I do expect this to be a little bit of a bumpy ride, but the end product is an extremely desirable one. Okay, I think all the comments there are very helpful. I'm sure you've taken them on board, Andy, and others who are thinking through this, and committee chairs and committee members as they think about what we're trying to do. Okay, it's 11:26, 11:27. You're due a break now, so 11:40, please back. Enjoy your coffee. Thank you very much.
No, mute yourself again. No, mute.
Okay, 11:40. We should all be coming back in now. Thank you very much, everybody. Elective recovery is the next big bit, along with theatre efficiencies and winter plan. So you'll note in this that there's a bit of work done on equality mapping. Now, on the non-exec director away day recently, it was clear the non-execs wanted very much to think about inequality and deprivation, and indeed to have a session on it in their next away day. So I think this is an area that is going to prove to be, quite rightly, a growing area that we should be focusing on. This is not just an issue for CCGs or other organisations. We have our part to play in this. So we'll come to that in due course. But initially, elective recovery. Faye, I think you're reading this, and then we'll start to go through the process.
Thank you, Chair. So as we've already talked about, I think as an organisation, we're doing pretty well from a elective recovery point of view. And in fact, we have some of the shortest waiting times across the country. So that's really good for our patients here in Kettering. So just to give you a bit of a flavour about where we're at. So from an RTT point of view, as we talked about earlier, we've been really driving down the number of 52-week patients that we have. And actually, we talk about 46 weeks now as opposed to 52 to ensure that we're driving down those numbers of patients. We did have 4 patients that didn't meet that target in August. And some of that was around some of our validation processes. But to assure the board, we've had a real deep dive into why that's happened, and we've started to surface some themes. So there's a number of things that we're doing with our teams in terms of validation, in terms of spot audits. We're also developing our admin academy, so we're really focusing on training. And one of the big things that we've put into place in the last couple of weeks is our electronic outcome form, which is completed at the end of each of the clinics. There's been significant work around that, which Rabia and her team have been working on. And this is a real game changer, I think, in terms of getting the consultants to complete that form at the end of the clinic. So that's really positive. So we'll continue to monitor that. But all in all, I think there's some really good work going on around our RTT position, and indeed family health and medicine have a wait time of a maximum of 30 weeks. So there's been some significant work going on around there. Our biggest pressure point is our theatres at the moment when we talk about delivery of our RTT position, and that in the main is around our ability to recruit staff. It's a hard to recruit area, and this is a national problem. But we'll also talk in my next report about how we've got some opportunities also around recovering our efficiencies within our theatres. So we talked earlier about cancer. Again, we met the target in June, which is the first time we've delivered that target since March 2020. In July and August, we're going to be around 82 and 83%. So we're just missing that target, but we continue to focus. And a number of patients that are sitting over 62 weeks, 62 days, sorry, is plateaued. So we've got a nice kind of even number there that we're not increasing. So we're really watching that at the moment. Our pressure points are in urology and colorectal, and there's lots of work going on with our teams around that. And we've just appointed 2 colorectal surgeons to Kettering, which is really, really good news for that service and our patients. In terms of diagnostics, again, in June, we met that target. But there's an ongoing issue with echo at the moment, which is the reason we're not meeting that target. And that in the main is around some maternity leave, some sick leave, but also the pressures of COVID and our staff being pinged, as we use the term, which is also affecting our capacity. NGH have been really helpful in providing some additional capacity, and we continue to work with NGH to for resolution of that problem. But we need a long-term solution. Again, technicians for cardiology is really a hard to recruit area. So we need to look to other solutions to how we grow our own teams to continue to provide that service. But all in all, as we've talked about earlier, I think it's a really good effort from our teams here at KGH, and we will continue to keep that pressure and that focus on improving that every month. So I'll pause there for elective recovery. Would you like me to continue to go on to theatres, or should we pause for questions,
just
Chair?
Pause for a moment on elective recovery, please, and see if anybody has any questions or comments around that.
Thank you.
Two hands went up there. Trevor first, please.
Yeah, thank you very much for that update. I think one question I've got is, how much are we still using the independent sector in this delivery? It's a very good position we're in. Extra percentage point here or there would be even better for the patients, but actually how much are we dependent on the independent sector, or how much, is that going to be playing in going forward? I suppose it cuts across the winter plan conversation later as well.
Yes, thank you, Trevor. So in terms of the independent sector, there's two particular specialties that we are transferring patients under, and that is ophthalmology and also endoscopy. Other than that, we are providing the service within the trust. That said, we are using a third-party provider and insourcing some capacity, particularly at the weekends, to help us with that. So not a huge amount. The majority of it is being provided within our own services with some additional waiting lists at the weekend. But yes, we are still using a small proportion of insourcing and outsourcing to maintain our performance.
Thank you.
Holly.
Thanks very much, Chair. Yeah, I'll just add a couple of bits to that. First being that we are working with the independent sector and working up some plans at the moment, Trevor and others, as to what our relationship longer term might look like. There is some longer term capacity coming online with the independent sector, and as a system we want to make sure that we're working together, and they're absolutely around the table with us on that to make the most. I think the other thing I would add from a system elective performance perspective is that whilst Kettering and Northampton as individual trusts are doing well, and Faye's described that in terms of our waiting times, we do have local residents and local patients who are waiting longer at other hospitals outside of this county. So I think it's worth noting that and saying that we are doing some work at the moment now to identify who those patients are, and if they are waiting for treatments they can have in this county, then we will be starting to work towards offering those treatments at their local providers at Kettering and at Northampton. So I just wanted to add that in from a wider perspective than just the organisation, more of our local population, Chair.
Debbie.
Yeah, thank you, Chair. I was on a a regional call yesterday with chief execs, and the ask was very much to continue doing as much elective activity as possible. And obviously mutual aid is now being asked for, as Simon alluded to earlier. I think it's just important to keep this in mind when we start to also think about our winter plan, because in previous years we would have, as a county, started to take decisions about whether or not we cancel routine electives and on occasions some urgent electives. And of course now that's definitely not the ask, especially with the number of patients that are waiting over 2 years for an operation. Thank you.
Lisa.
Sorry, I thought you were going to go to Simon first. I think it's brilliant. I think the position is really strong, and I think many trusts and areas would really like to be in the position we are. That being said, I was just slightly concerned about the comments around recording of RTTs, given our previous history in some of these areas. And I want really to get some assurance about ongoing how we make sure that our RTT recording and therefore our performance reporting is absolutely accurate.
Yeah, so thank you for that. So, I mean, obviously some of this is human factors, but so the things that we need to put in place, we're putting into place in terms of the validation. So we are having real focus on not just patients on an RTT, but also on a non-RTT pathway. We're also doing some spot audits, and I think training is absolutely key. And one of the things that we've been developing is our admin academy, and that's due to be launched very soon, and that will really help us focus and make sure we're training people to do their job. RTT is complex, particularly around the coding, but also I think the electronic outcome form is a game changer for us. But what we have noticed is from doing the spot audits and the validation is that there's been a bit of a theme. So the theme is that when patients have gone off for tests, some patients, they've been added to a watchful wait, when in fact what should have happened is they should have been added to a waiting list. And there is a definite theme throughout the patients that we're auditing. We've not found anything else, and I think that is what we're focusing on at the moment. So validation will continue. We are validating right at the front end of the pathway, and all patients at 30 weeks as well. We will continue to work on that.
Okay, thank you. I'm sure quality and safety will continue to have a look at that from their perspective, but there are other committees who might want to look at it as well. As Lisa's quite right to bring up the historical fragility of this area. Simon.
Yeah, a few points. Firstly, thanks, Lisa, for your comments. I mean, we just recently went through our quarterly system review meeting, and our position on these metrics was noted. And the fact that we're being asked to help out is reflective of the progress that we've made. You're right, we need to pay constant attention. Validation is never something that is completed. You've always got to go back to it. And I'd encourage all committees to continue to review it, but particularly I want to note and thank people for the introduction of the electronic outcome form, because I think that does really change our ability to make sure that people don't fall through any cracks in the system. So checking up on compliance with that and making sure that people aren't sitting languishing, waiting, or not being followed up with an appointment or whatever is going to be a key task for the operational teams. So the third point I wanted to make really was that it's really I think Trevor put a comment about funding for all of this in there. The truth is that the money of the demand, it's a question of how much the gap is and how much we can close it. So structurally in Kettering, one of the issues that the unappointed referrals issue threw up was it exposed a systemic lack of capacity in some specialties that will need either resolution through some of the clinical strategy work or additional funding. But we should be under no illusion that even making sure the validation is completely addressed as a task, the validation in itself has revealed a different type of issue that we will need to grapple with, both through our own strategy, but also through how we fund certain services to meet the demand that we know is out there.
Okay, thank you. Sorry, right. Yes, okay, fine. Finished with that. Do you want to move on, Faye, to the next bit of the item?
Yeah, thank you. I think we've got some slides, Kieran.
Yeah, I'll just share the screen.
Thank you. Okay, thank you. First slide. Do you want to go on to the next slide, Kieran? Thank you. Okay, so theatre utilisation, as we've alluded to earlier, it's pretty critical and key in the delivery of our RTT performance. The national standard is that we get to 85% usage of our capacity available to us. And you'll see shortly in the presentation that we've got some way to go here at Kettering. NHSEI have made this a priority, and we're now having to provide data on a fortnightly basis on 4 key metrics, which are touch time, utilisation, late starts, early finishes, and inter-case downtime, which we'll talk about a little bit further in the presentation. So thank you. Next slide. So this slide gives you a little bit of a flavour about what the journey, I suppose, of a theatre list. And as you can see, we've got 4 operations on here, and you can see where there are opportunities for inefficiency. So we've got late starts. If we don't start the list on time, that's missed opportunity. We've also got the inter-case downtime, which is the time between each of the cases. And we've also got, at times, early finishes. So as you can see, there are some opportunities there for us to work on. So as we've just said, these are the drivers, and these are the things that we need to really focus on. And there are a number of reasons that late starts happen. Some is because patients aren't ready, some are because the notes aren't ready or equipment isn't ready. So there's all sorts of things that we can look at there. In terms of downtime between each of the theatre lists, this could be down to lack of equipment, it could be the cleaning of the theatre, it could be waiting for the next patient. And early finishes, obviously, you know, they could just be the timings of the list that we've put together. So all of those things are the drivers and things that we can work on. So the 85% is calculated based on when the patient enters the anaesthetic room, so when they get their anaesthetic, and the point that they leave recovery. And then that's divided by the total session length, which is normally 4 hours. Next slide, please. So this just gives a flavour about where we're sitting across the country. And as you can see, Kettering is sitting sort of at 75%, and you can see that there's huge opportunity. Other trusts are achieving that 85%. So we need to absolutely learn from that and take those things forward. That said, it's pretty standard approach, really. Those 4 metrics are the things that we know we need to improve on, and will definitely help us move towards a more sustained performance within theatres. Thank you. Next slide. So this shows us where we are at here at Northampton and Kettering. And as you can see, right at the beginning of the year, we were really not in a great position. What you can see is over the last few months, there has been some improvements in actual theatre utilisation, but clearly we've still got some way to go to get to our 85%. Thank you. Next slide. This also shows where we're at in terms of late starts, turnaround times and early finishes. And I think, you know, there's a theme there that basically says that we have opportunities within our theatres to do better. Thank you. Next slide. So over the last few months, we've been working really hard as a group to come up with a group transformational programme. And there are a number of things that each of the organisations are looking at. But what's really good is we now have a consistent dashboard across the group. So we can really start to understand what's going on in each of the theatres, under the specialties, under the consultant. So we can really deep dive into what's going on almost on every list, really, and also with each of those metrics. So the group transformation is being led by myself and Joe at NGH. Each site has their own weekly meeting, which is a really focused meeting in terms of what are we doing about our turnarounds, times, etc. And there's a whole programme of work that's happening at each of the sites. There's also lots of work going on in terms of observational studies, so time and motion, how long does it take a patient to get back from theatre, is there things different that we can do? And as you can see, there's a number of things on here that we also need to look at in terms of cancellations and DNAs. It's also about improving our staffing and looking at the behaviours within our staff. And actually what I've noticed from some of the meetings that I've been to, there's a real appetite to change the way that we're doing things. So I think it's fair to say that whilst there's been improvements over the last couple of months, and those things haven't happened on their own, they have been driven by the divisional director in surgery, we still have some way to go. And this will be kind of a multi-professional attack, really. And we've got some clinicians, anaesthetists and surgeons on our working group. So I'm really confident that we will start to make some progress with this work. So I'll pause there for any questions. Thank you.
Okay, any questions on that work at all? It's not it's not a bad bit of work to address it, but it's not a good story in the first place about performance. Edmund and then Chris.
Thanks, Faye. In your presentation, Faye, you talked about improved scheduling. How do you currently do the scheduling? Do you use automation, and what are you planning to do to improve it?
Yeah, so I think it's fair to say it's different across all of the specialties, and this is something that we absolutely need to look at. It isn't automated at all, and I think it's a big piece of work that we need to do. In a previous trust where I've worked, we had some software that helped us do that, and it was really kind of an intelligent piece of software that built up over time. So it learnt to tell us how long it would take to do a hernia, for example, or how long it would take us to do a lap chole. And after a time, you could see instantly from a dashboard, what capacity that you'd got based on that clinician's flow, I suppose, workflow. So we don't have that at the moment, but that's something we definitely need to look at. Some clinicians like to book their own lists. Some waiting list offices book that based on their experiences of what they know with the clinicians. But there's definitely some work that we need to do around that space.
Chris, this is your specialist subject, really, mastermind specialist subject. So go on.
Thank you, Alan. I don't know where to begin over the last 30 years, but can I just say it's a really good paper, and thank you very much. I think it's one of the best I've read on this topic. But there is one issue that I want to take you up on. Slides 3 and 4 contain a definition of start time of an operation as needle to skin. I would say to you that that is out of date, and that the start time of a procedure is when the team gather to go through the WHO checklist to make sure they've got the right patient, they are undertaking the correct procedure, not the right one, and that they have got the appropriate equipment. Then you can start the procedure with an anaesthetic. So if this is an NHSE definition, I am extremely disappointed. If it's a local definition, could I suggest that it be amended? Because almost every organisation, every provider in the country has had never events concerning either the wrong patient, the incorrect side, or the incorrect procedure. And unless you carry out that checklist, we will go down that route. And saving 2% of theatre time is completely counterproductive if you have the costs of a never event. So I would hope that someone could look at that as a change of the process. The other issue for me over the years has been late finishes. And when I look at the chart, the bar chart, the 2 trusts that are about 120%, I really would want to understand more about what they are doing, because it is equally challenging. Thank you.
Yes, thank you for that. And I think it's crucial that that every surgeon is following the WHO checklist. And I'm sure, well, it'd be interesting to make sure that that's part of the validation process. Thank you for that contribution. Andy.
Thanks. So on the definition thing, Chris, I'll take up the action to look at that. Some of this will be down to model hospital definitions that we conform to, but I will take that action to confirm. second bit around the predictive element, we've done some work to move the theatre system that we had into a better one. So that was done at the end of 2019. There's still further modules to be enabled within that system, but so what you've identified about scheduling is definitely on the radar. There's a piece of work that's just happening at the minute that's funded by NHSX that we are looking at bed scheduling on admission, and the type of the technology that's being used there will be applicable to lots of different things when it comes to scheduling. So we're in the process of learning more about that, building our capability, which will then help with lots of other things.
Okay, thank you for that. I suppose I only commented with every surgeon I've ever known knew exactly how long it took him to do every procedure he ever planned. So I'm sure there's a capacity there for automation. Edmund, and then Simon, and then we'll move on.
Thanks. Just to come back to Chris's point about the definition, if we're looking at comparisons with other trusts and looking at benchmarks and so on, surely if those comparisons don't mean very much if the definition is not the same. Have we got different definitions in different trusts? And if so, are those comparisons telling us anything?
I think the answer to that at the moment, Edmund, is probably we're not very sure, but I think the chat shows that we're going to find out, and Andy will go away and make sure we understand that. Simon, final comment on this before we go to the health inequalities bit.
Yeah, so I hope board colleagues welcome the start of this debate. It was it is intended to be a start of a continuing conversation. And I would encourage colleagues across committees, but particularly obviously finance and performance, to continue developing the dialogue around this, is the first point. Just a few very rapid fire points from me. Edmund, I think the model hospital data often provides a superficial consistency, but in actual fact is underpinned by different definitions that are applied locally. It's one of the problems with the data set. And so I think the challenges that Chris has raised and you've raised need to be picked up in that programme as much as, and regionally as much as we need to address them locally. The second point to raise is, of course, just drawing out the clinical strategy conversation again that we're going to have on Friday. There's a question for us again, and I'll just continue to draw links here. To what extent do we want to be more ambitious about consolidating surgical specialties and protecting capacity on certain parts of our estate will be a question that we need to grapple with. So as you approach the clinical conference, think about the data that you've seen here and think about, does the response in terms of the service offering allow us to really progress further in terms of how we might do better on some of this stuff? Because the truth is, of course, that non-elective demand for all hospitals crowds out some of this work. And then the point that Damien made, and I think Alan's made it too, about superstranded. What price to us if superstranded go down? I think you've said that often, Alan, and I get, again, underpinning this debate, there are issues of grip and flow and discharge and admission that we need to grapple with. So here's the link to ICANN and what ICANN needs to deliver for us as a system, because if we get ICANN right, then there's no excuse for us not to do better on this stuff. I'll leave it there. Thanks.
Okay, thank you. Clearly work in progress, clearly an area of massive efficiency gain. And I take all the points about late running and early finish and everything. Some of that will be endemic to particular specialties or surgeons. But I think exposing the data, it's not a black box in there just because there's a red line on the floor. Let's expose the data and let's start to unpick it. And there will be many things that can be done to improve it. It's probably our major capital asset. It's the area everybody says is the choke point, lack of staff. So it's an area we have to use with great efficiency. Thank you for that. Who's doing inequalities paper?
Chair, I'll be starting that with the help of Faye.
On you go.
Okay, so I'll just share my screen and just take you very briefly through the paper. It's worth noting, as you've indicated, Alan, that this is very much the start of this process, and there's plenty more to go at. But just want to share with the board where we've looked at. So, linking to the information that Faye shared earlier on around the number of theatre sessions, that same information from April to August has been looked at in terms of the number of patients, and then those patient information relayed over demographic and protected characteristics where available. So just as sort of definition of indices of deprivation and the postcodes within Northamptonshire, it's worth noting that within Northamptonshire, we've got some of the very highest levels of deprivation. So the lower the number, the higher the deprivation. In England, the maximum number, as in the least deprived, is 32,844. So you can see, as a county, we've got a massive range of that. When you look at the data, and if you order these from left to right by deprivation, you can see that the NN2 and NN3 patients are more concentrated at Northampton, the more deprived areas, and the areas 14 to 17 are sort of associated around Northamptonshire. It's also worth noting that this data is only for those within Northamptonshire, and you'll see that Kettering has 7% of patients that are from outside the NN postcode area, and Northampton has 4%. If we look at the same data, but this time ordered by postcode, and you'll see actually when you overlay that, no surprise, I suppose, that the location of patients broadly aligns with the Kettering and Northampton hospitals. So, in terms of demographics, there's probably more to go at here. What we're seeing is there isn't necessarily a lower number of people who are getting operations from more deprived areas, for example, as a proportion of the population. If I just move on to age, you wouldn't expect age distribution to be proportional to the population, and what you see here is that the number of people within elective activity is much lower as a proportion of the population below the age of 44. The crossover point is between 45 to 64, and then thereafter the proportion of the population who are having electives is much higher than the general population. Again, we probably don't want to draw too many conclusions from this, but probably what it does is confirm a hypothesis that was we expected, that the older people are the ones who are having more operations. And then finally, by ethnicity, what we are looking at here is a spread of elective activity that broadly follows the ethnic distribution across our county. Just noting that at Northampton, there's quite a lot, 14%, that are not known, which has a skewing effect over all the elements across the piece. And you'll see that sort of broken down there, and that includes those where the patient isn't asked, or the patient refused, or the information just wasn't available. So Faye, if you're joining here around the actions taken. Clearly, there's more to go at here. There's lots more in terms of drilling down into this data, not just for elective, but also other areas. So, for example, what we saw here was around those who are actually in receipt of elective. We will need to look at the waiting list in the consideration of ethnicity, race, etc., deprivation, and there's more to go. And there's certainly a gap there in terms of looking at the recording of an ethnicity across the group. So we're more uniform and picking up the gaps, because if we don't record it, we can't identify where there may be a bias or some inequality. Faye.
Thank you. Yeah, so I think you're absolutely right. It's just the tip of the iceberg, isn't it? We're just sort of beginning to on our journey to look at this. I think to assure the board in terms of how we prioritise our lists, you know, we are literally taking from date order or clinical priority. So we don't at the moment look at ethnicity or age when we are listing our patients. But certainly, I think the concern for us needs to be around, well, who isn't accessing our services, who's DNAing, who's not attending, who's cancelling, and whether there's something there that we need to look at. But as Andy says, there's a number of things that we need to look at. One is around the system actions that we need to take. And I know that Polly will be looking at that at the System Elective Care Board. I think as a group, we absolutely need to be focusing on a deep dive into on both trusts in terms of what is it we need to do, what data do we need to capture. And at a hospital level, we need to be focusing on this at our elective care boards that both organisations have. But I think as a priority, maybe doing a piece of work initially on our DNAs and our cancellations would be a starter to look at. Thank you.
Okay, thank you. I think there's a couple of ways to think about this. Clearly, we have a responsibility for the people who are referred to us, and there are some suggestions in the data on ethnicity that would point us to some problems in how we handle that. But there's also a big issue for the system in that much of this comes out through GP registers and the way GPs handle patients and how they organise their patients and referral thresholds. However, I'm not going to pontificate on this. We have somebody with a mastermind specialist subject in it. So Dr. Llewellyn, tell us what you think about inequalities and what we ought to be thinking about both as the system and as a group.
Thanks, Alan. Better not mess this up now then, having had that introduction. It's a great start, but I wouldn't want anybody to walk away from this data saying we don't have a problem, because at the moment we don't know. So we've looked at sample data, 6 months data. We haven't age standardized it. Andy's presented a slide that really shows the impact of age. So as you get older, you're more likely to have an elective operation. That's kind of intuitive, isn't it? So what you have to do with all of these communities is age and sex standardized. So we have to look at those populations taking into account the impact of age. Otherwise, you're just not comparing apples with apples. But it's a start. And as Andy said, it's also about the people who've had the operation. And what we also then need to do is look at specialties. So if you look at the King's Fund, and there's been quite a lot over the last few weeks about this, actually, if you look at kind of what they call indicator operations like elective hips and knees, there's been an increase in the number of people in the least deprived areas having those operations over the last 10 years, and a reduction in the most deprived, which is not what you would expect or would hope, because actually joint disease is more prevalent in the most deprived. So we have to look at it specialty. And then, as Andy also said, we need to look at waiting times, because what we're seeing is the people who've come to the top of our weights and are getting their operation. What we haven't had a measure of is how long they've waited to get to the top of the priority or for their turn in order. And whilst the hospital has an impact on that, actually that's a system issue. And it's a real debate to have with the system about how we look from presentation of symptoms through to actually receiving your care. And I think that will be a really interesting conversation to have. Thinking about what we can do at the moment, people on our waiting lists, Faye, I think it's a really good idea to look at DNAs and cancellations. But also, I think, Andy, it's possible to pick up people with characteristics on our waiting lists that would put them at risk of a worse outcome. So who's got diabetes, who's got renal failure, who's who's got high BMIs, so that you can actually put some targeted support into those. And those, of course, will be more prevalent in certain communities. And then finally, actually, what we all want to get to is, are we getting equality of outcome rather than equity of access? So we need to get people all having the access according to their clinical need, but also we need to look at that equity of outcome. And I'll take a breath, because I could go on for quite a while, but I think that was sufficient. But no, really excited. And, you know, the offer is here to support and to just kind of give any advice as needed.
Thank you for that. The other thought that occurred to me as I looked at the data is it's well known that people from less deprived areas or higher social class will access the private sector under NHS choice regime. And that would be quite a skewing factor for a lot of this. We might look as if we've got the equality of data, but actually there's a large chunk going on funded by the NHS in a different place. So it becomes a system-wide analysis. But it, as Lisa says, it's a good start. We have an expert there, so we should use her. And we need to think very carefully about how we take it forward. I'm very pleased that the non-execs as a group think this is a very important area to address, and we will be talking about it in the next away day, as we will be talking about it at other boards. Any other comments on that bit of work at all? No. Okay, guys, so far so good. Big topic. Very keen to see it, and the Times report on the King's Fund work was pretty damning about the waiting times for more deprived areas. So we need to think very carefully about it. When to plan? Debbie, I think you're leading this one.
I am, thank you, Chair. And again, another big topic, and of course we will also in part 2 have some more time to talk about winter and our plans. So before I hand over to Andy and Faye, I'd just firstly like to thank them both actually for the enormous amount of work that they've actually put into this. That's both the capacity and demand plan and then the subsequent development of the schemes, which we obviously need to implement over winter. So I'll just start by saying we've made some assumptions to get to the worst, most likely and best case capacity requirements. The model it's really quite good. It's agile enough that we can then change our assumptions should we need to. The most likely case is what we're going to be focused on at the moment, and you'll see January as our most challenged month. But the schemes that we plan to put in place will mitigate that. So I'll firstly hand over to Andy to talk us through the modelling, and then Faye to talk through the schemes.
Thank you. If you have the next slide, please. Just worth, as we go into this, just a reminder that this famous quote from a statistician, I think hopefully what colleagues will see is that actually this has been useful and has illuminated many conversations at an operational and strategic level. So next slide, I'll just talk you through the components of the model. I won't go too much into this, but these are the various elements that can vary in the model, and I'll talk through that on the next slide, please. It's worth noting that this is for adult inpatients, so pediatrics have been modelled separately, and you'll see if I start at the top left hand corner, the input into the funnel, if you like, of ED attendances is based on 2019 calendar year. For obvious reasons, 2020 isn't used as a reference, but what we've seen so far in this current year is that 2019 has got a very similar profile to 2021. Also into the ED, there's admissions not via ED, so direct referrals, etc. Those combined together with the conversion rate give the total ED admissions. So that's the first kind of reference point within the model. And of those, some of those don't result in a length of stay greater than the 1 day or greater. And then that's split up into the 3 divisions. And that there's a pretty uniform split between those 3. Once you've got into, if we take medicine first, of the medicine admissions, medicine varies quite considerably throughout the year in terms of length of stay. So there's an individual length of stay profile for the best, likely and worst model for medicine. In terms of surgery and family health, it's got a quite consistent length of stay throughout the year, so that's a fixed number. Once you plug all those things in, you get a number of bed days required for each of those divisions, and then that ends up with the total beds required. So that is our gross bed deficit once you take off the bed stock. Next slide, please. And once you've got your gross bed position, what you'll see in the model is there's a number of winter schemes that then can be applied to improve the bed position, and you end up with the net bed deficit and surplus. So we'll go through and sort of talk about those various components and the output of the model. If you have the next slide, please. Worth just having a common understanding of what the scenarios are. Target occupancy is 90%. Colleagues will know that 85% really is the most desirable target in terms of maintaining good patient flow, but we've used 90% in this model. Length of stay has been actuals between April and July in the various cases, and then estimated based on historical profiles for the remainder of the year. And the bed position is presented as gross. And then there's some other things that are already incorporated into the current figures, such as pneumonia length of stay in KGH and the split between the divisions. Next slide, please. So when we apply those things into the schemes, we end up with, in the likely case, a deficit of 38 beds. If I hand over to Faye to talk about the mitigation schemes.
Thank you, Andy. Yes, so we've got a number of schemes that we've been working on probably since May time in readiness for this winter. So the first thing that we're planning to do is open a winter escalation ward, which is Poplar, and that will give us 29 additional beds, which will obviously mitigate some of that risk. We've also looking to put in some additional roles at the front door, which will help stream our patients to the right place right at the outset. And what we hope is that we'll see an increase in our patients that through our SDEC service, which basically means that we can manage patients in an outpatient setting rather than admitting them and bringing them back the next day to continue to their care as an outpatient rather than popping them into a bed. The next scheme is around therapies, and we've done some pilots over the last couple of months around how we can ensure our patients stay at home and not need to be admitted. And the team have worked on a number of schemes around frailty particularly, and that enables us to maybe provide some wraparound care to keep them in their home or to start their rehabilitation at home rather than bringing them into a bed. Our virtual ward is something that we implemented back during COVID actually, and has been really successful. And at any one time, we have about 20 patients that we're caring for in the community. And that's a scheme that we absolutely need to continue during winter to keep those patients in their own home. They're often patients that are on oxygen, and that would be their only reason really for being in an acute trust. So really important that we push ahead with that one. The next one is around simple discharges, and we're looking to enhance our discharge team at the weekends and during the week so that we're really focusing on getting our patients out as quickly as possible. And that means focusing on patients that are with us for up to 7 days, but really focusing to get them out as quickly as possible and doing the right thing. The last thing we've got on the list is phlebotomy, and this really is around how do we get our patients home as quickly as possible on the day. Often we don't see our patients going until late into the afternoon, and so we're going to invest some time in our phlebotomy service, which will enable us to get those bloods taken early on in the morning so that we can get some decisions made on the ward round and we can get patients home. And if we deliver all those, that will give us a net of 6. There's still more to do. We've got a number of schemes in addition to these, but these are the ones we wanted to bring to your attention today. So if we go on to the next slide, I'll briefly talk to you about paediatrics. So paediatrics, we've been asked to model our paediatric capacity based on 2019-20 RSV cases, and we were asked to look at that for 20% and an increase of 50%. And what you can see is basically we're going to need 40 beds to provide that service for our paediatric patients. We've got a number of things that we can put into place here on this site, and you can see from the presentation that they are documented there, and that will then give us a deficit of 6 beds. In order to bridge those 6 beds, we started to have conversation with our NGH colleagues about how we can look at pathways to move patients as clinically appropriate to Northampton. We hope not to have to do that, but if we do see these numbers come through, that is something that we will definitely be exploring. In addition to that, there's a number of community schemes that are being worked through, a national programme called the Community Hub, and we're just waiting from our system partners for some data on what we think that impact will have. And of course, once we've got that, we can overlay that onto our model. Thank you. Next slide. So we've already talked about elective care earlier. I think both trusts are fully committed to providing a service for our urgent and cancer patients, and we will continue to do that. As Polly talked about earlier, we're also working with our independent sector colleagues around what is it we can do to keep work continuing and our patients still having their operations. I think the other thing is that we may find that will impact on us is in terms of critical care. So we've seen a significant demand over the last few weeks for critical care capacity, not necessarily COVID related, but as we go into winter, we may find that we need to go into our surge plan. And if we do that, it may impact on our theatres because we will need to release our theatre teams to support in critical care. We are working on another plan around how we can mitigate that. But if the numbers do rise significantly, then that is something that we will need to consider. We're also working with NGH on, are there any services that we can co-locate during winter to ensure that we keep some elective work going? So there's lots of things we're also exploring at this point in time to see if there's anything different we can do to keep our elective services running. Thank you. So next slide. Thank you, Kieran. So critical care, as I've already alluded to, has been under significant pressure. We have been surging into our escalation plan over the last couple of weeks. And as I said earlier, it's a combination between COVID patients, but also other demand. Should we need to surge any further before we start looking to take our theatres down and using our staff within theatres, we will be obviously seeking support from the network. There's a well-established critical care network across the whole of the country, and we will seek mutual aid before we think about expanding our beds. And obviously what that will mean is that we will transfer our patients based on clinical need and suitability, which will obviously be facilitated by our critical care consultants. Thank you. So winter has a number of challenges, I suppose, and some of which we've already alluded to. We have a winter plan, which is led by Debbie and is a system-wide approach. But I think one of the big risks to us is around social care and their inability to recruit. And as we talked about earlier, there's lots to do in that space. And as an organisation, we are trying to work with them to explore creative ways to try and support them to enable our patients to be cared for in their homes or their chosen pathway. One of the things we do need to consider is the impact of COVID and flu. We don't know what that looks like right now. We've got some thoughts. We know it's going to be a busy winter, but we just need to recognise that could have an impact on us. But from our point of view, we have strong IPC guidance and processes in place. We're screening our patients at the front door, which means that we can get patients into the right beds at the right time, and thereby mitigating any need for further isolation. Obviously, we've got staff to consider, staff that are really tired, and obviously with the PIM-demic of our patients, of our staff, that is impacting on our ability to staff some of our wards at times. So we just need to just be mindful of that impact. But I think where we're at the moment is we have a plan with a number of schemes. Yes, there are some risks, but we are working really hard with our system partners to mitigate where possible. I'll pause and hand back to Debbie. Thank you.
Thanks, Faye. So at this point, the winter plan is for information. Simon and I will be having a discussion later on with system chief execs around the additional schemes that both acute trusts can put in place. And that's simply because the immediate schemes that we'd agreed to put in place across social care mainly are not coming to fruition because of difficulties in recruitment. I think we also are challenged with regards to the outcome or the outputs of those additional schemes across the community and what that then means to our bed model, not knowing whether or not we'll be able to recruit 10, 20, 30 or 100% of domiciliary care staff. So stop there and perhaps take some questions, Chair.
Okay, thank you very much. We have a session on this winter plan in the afternoon session today, so if there's anything you want to say in this session, please do, but bear in mind we have an opportunity later on. And the message from a public point of view is it's going to be a very difficult winter, and having a vaccination against whatever you're offered would be quite a good thing to do, whether that's flu or COVID. So a couple of quick comments and then we'll move into the next item. Alice and then Trevor.
Thank you, Alan. Just quickly, Faye, on slide 7, where you're looking at the adult plans, I guess just a bit of a sort of sceptical question around looking at the impact of our proposed measures compared to Northampton. My first question is, they seem to make a much more significant difference to our deficit, we're assuming, than Northampton is assuming. Are we comfortable? Can you give us some assurance that we're being, I guess, sufficiently sceptical about the impact of those measures and that we're not being over optimistic compared to our peers?
Faye, you're just on mute.
On mute, Faye.
Thank you, sorry. Yes, so we've been working on our plans since May, and we started off with nearly 30 schemes, and what we've done is robustly go through those almost every week, check and challenge, and really get underneath, do we think these can deliver? As I said earlier, the therapy one, we have absolutely piloted and tested those. But I think our biggest gain here is Poplar. That immediately gives us 29 beds. So I suppose we're in a fortunate position that we've got some capacity that we can switch on, unlike colleagues over at NGH. So that's probably why you see such a significant variance between the two organisations. But like I said, I think we have been working on this since May, knowing winter was coming and how difficult it was going to be.
Thank you, Faye.
Thank you.
Trevor and then Lisa, and then we'll move on.
Thank you, Faye. I'm sure I'll have some comments later, but my key one now is you talk about discussions with system partners. One of the issues on paediatrics over the last few years has been the use of paediatric beds for patients that more appropriately should be in CAMS beds. So is there any move from NFT to actually, with partners, deal with the lack of CAMS beds? Because clearly that's it's not a winter issue, but it affects our baseline.
Yeah, sure. Okay. That is something we haven't explored, but and I don't know if Debbie's got any comments on that, but that is something I can definitely pick up with NHFT colleagues for sure.
Yeah, thanks, Faye. So you're right, Trevor, this is a national issue, and it's again, it's not just winter. I know that NHFT are working really hard about how they keep these children in the community and really well supported. What we are planning to do in that space is make sure that we have got mental health trained nurses within our organisation who can then support on Skylark ward if needed, if we can't move patients out quickly enough. So we mitigate the risk internally. But I do do know that NHFT are working on plans to increase capacity in the community on this.
Okay, thank you, Lisa.
Yeah, just a comment really. Have we looked at our local council's budget for this year to see if there have been any changes in service that you wouldn't automatically look at? So I'm not thinking about social care, but things like roads, things like social support in the homes. So things that actually insidiously, if they start pulling back, actually will increase the pressure on our emergency admissions. So just a thought, no need to comment, but it might be worth a look.
Okay, thank you.
That's a helpful thought. I remember many years ago when a local authority not too far from here decided no longer to grip pavements, and it produced 232 orthopedic fractures in a weekend. So it is, that kind of thinking is very important, and I'm sure somebody will pick it up and look at it. Okay, thank you guys. I'm very conscious of time now, and I want to give enough time to the next item. So Mark, off you go, and take us through it reasonably promptly, please.
Okay, thank you, Chair. Colleagues will be pleased to know that I have an amended report to that was circulated beforehand, which is a bit more streamlined, which will obviously help with the reduction in timing on this particular item this morning. So I just wanted to go through a couple of elements. So if I could take the next slide, please, Kieran, thank you. So we have our people plan, which we signed off 6 months ago, almost to the day at the end of March. We had a clear strategic ambition and a priority set in relation to our dedicated to excellence strategy, and our ambition, which is to be in the top 20% of acute trusts in the National Staff Survey, which I've had some feedback this week, which is extremely ambitious, given all the things that we're trying to do and to achieve as a group. But I still think it's the right objective to set ourselves. It's important to set ourselves stretch targets and make sure we try to achieve them. I'm not going to go into this in too much detail because quite a lot of it people already know. So we have 7 pledges within our people plan. We have a number of deliverables that were set out in terms of what we would do in the first 12 months and what we would do over the duration of the plan. And also, obviously, the biggest elements of that was to understand where we were in more instant people feedback for our people pulse survey, which has already been well trailed today and was launched during September. And I'll come on to give a little bit of information around that in a second. And we also then have the element of the teams. So the team that work with me and for me within Kettering and Northampton, we are in the process of bringing those teams together in order to deliver the plan in line with our pledges. So rather than having duplication, we're looking to coordinate that team to be able to take forward the plan. And whilst we have some transactional elements that we need to work on now, the only way we'll be able to do all of the transformation work we would like to do as a group in organisational development will be to take some resource from transactional services and put them into transformational services, which I have to say totally fits in line with the national people plan and deliveries as we move forward. So if I could take the next slide, please, Kieran. This is a reminder of the 7 pledges. Again, I won't go into these in any great detail. It was only 6 months ago, literally, that we produced this and said what we intended to do. If I could then take the next slide. So this is the shorthand version of the pack that you have. This is what's happened in the first 6 months in regards to the plan and what has been achieved, and we'll come on to what hasn't been achieved, which is a source of frustration and what we will do in the future. But in the first 6 months, you can see here, hopefully there are a number of activities here, of course, and we'll put these on admin control so people can read through them later. But we focused our attention in the first 6 months on responding to the feedback from our National Staff Survey of 2020. We focused it on a post-pandemic, what people were requiring of us, and to call out 2 specifics in regards to that. We have equality, diversity and inclusion, and obviously health and wellbeing and the agenda around how we support our staff and colleagues. We also have worked really hard on international nurse recruitment, again, which has been discussed here and in previous people committees in terms of our progress in regards to that. And that's no mean feat. So across the group, that's to bring in 396 additional colleagues this year to support our nursing and midwifery strategy and indeed the care that we wish to provide to our patients. So it's been really important that we focused on national people plan priorities and some of the health and wellbeing and equality and diversity and inclusion priorities within or pledges within our plan that we were not so advanced with, and we've taken those forward, which you can see here. And again, some of these were referenced earlier in the presentation today. So from Debbie as an example, the outdoor gym that's been installed in KGH. We've also been learning from one another across both hospitals in Northampton and Kettering. So we know in Northampton, we were lucky enough to be successful as Health and Wellbeing Employer of the Year for 2021. And what we have adopted now into Kettering is the Support Our Staff service and the psychological support that brings locally into our workplace. But also we've worked across the system in bringing together the Stronger Together support hub, which is access to people who require any mental health services at a much quicker rate than they would have that otherwise. And that's open to all staff on both sites and indeed in and around and across our system. So we have lots of work that we've been working on through here, which is in line with some of our priorities. However, if I can take the next slide, please. We know that there are a number of sources of frustration in and around our work across Kettering and indeed Northampton as we come together and have formed the group post our group launch on the 1st of July. And therefore, really what I'm going to set the direction of my team, myself and my team, on in the next 3 months is what I'm terming process and consistency. So we are not one organisation, we are two sovereign organisations. However, there is lots of work that we can do in terms of process and consistency. One that we have seen in the recent past, indeed it came to our board meeting in July, is our policy development. This, if I'm honest, hasn't been as quick as we would like it to be. So we need to put our hands up to that and we need to do something in expediting that. Our disciplinary policy took a long time to agree across both hospitals and therefore as a group policy. And we need to work through the rest of the policies in a more expedient way by setting up task and finish groups, which we will do in the next 3 months. A good example of that, and we will hear about this in the clinical conference on Friday, is in regards to our job planning policy as an example. They're not hugely different between Kettering and Northampton, but there are some nuances that are different, and they can really be blockers and instead of enablers in terms of helping people progress and move forward in their change processes. And we've seen that in some of our services that have been working through collaboration in the last couple of months. We need to look at our rates of pay across the two hospitals. Not a week goes by at the moment since the launch of the group where this doesn't get raised to me in one way or another from a different staff group or another. So I'm really going to be setting out some clear stalls around this in the next 3 months as to who is able to look and increase rates of pay, firstly in the temporary staffing arena, and then we need to look more in the substantive arena with regards to jobs and roles that we're asking people to undertake in both hospitals. There is some disparity in roles that we ask people to undertake and therefore grades, but also we need to look at this in a really close context as to, of course, when people are raising these concerns, they're not raising them on the basis of and therefore we all expect to be less. It's a case of how do we equal up, and clearly that wouldn't be affordable for us as two separate organisations or indeed as the group. So we need to work through those in a systematic way and be clear as to what our expectations are for people in both hospitals and indeed the pressures in both hospitals from an operational and a perspective. And as we move into the winter, as Faye's just described, that will obviously intensify, so we really need to work on this soon. That being said, John and I have appointed a post holder to come in and start, and they start Friday, to come in and start this work for us. So this again isn't something that's going to be done in the next few months or years. This is going to be something that's done in real time in the next couple of weeks. We have a memorandum of understanding that we also need to work through in the next 3 months, well, even quicker than that, which will allow colleagues to work between one trust and another. So it will remove any duplication in recruitment or in honorary contracts, those age-old things that everybody who's worked in people service will remember. We will have the ability to freely move and work between one site and another without having to undertake all of those checks and liabilities for each organisation. We will be able to do that very much more seamlessly based on the memorandum of understanding and a consistent employment contract. So again, it may seem a basic operational thing to do, but again, it just demonstrates where we're heading as a group, and we need to make sure that consistency starts at the point of employment, therefore not requiring the MOU as we move into recruitment further down the line. So there's some real process consistency bits that we're really going to pull out in the next 3 months, and we would love to be in a more advanced position in relation to those, but we're not. So we need to address that and do something about that, particularly as our clinical strategy is developed and further discussed, and we know it will be coming to our board at the end of November, these will become more prevalent for people. And obviously one of the jobs in these group roles is to remove barriers such as these. So we'll be working really hard on that in the next couple of months. We also have in place, we're starting to review our organisational development requests and work that are coming our way in terms of what people are asking in terms of interventions. I talked at the CPC when we talked about this for a long period of time earlier in the month, that we had 23 requests, we've now got 34. And so we're having to look at these and risk and RAG rate them in terms of what level of intervention is required, the impact of said intervention, and where it sits in our priorities as a group in our dedicated to excellence strategy. So we're currently undertaking that as we speak. We'll also be responding to our People Pulse feedback. I'm so pleased that during the month of September, we were able to launch our first People Pulse survey. And that's given us some real good indicators as to what people think and feel working across both hospitals at the moment, which we will undoubtedly bring back to the board and provide you and indeed the People Committee with that level of information. The three headlines, if you like, from me at the moment, which we discussed at our group executive meeting yesterday in relation to the group, because we asked questions specifically of the group. Do people understand the group and the benefits or the purpose of the group? So we'll be restating some of that in the near future. There is also an element of teamwork. So how do we further emphasize where there is positivity in teamwork, but equally how do we address areas where teamwork is not where we would desire it to be? And the third one, interestingly enough, again, as we move in the post-pandemic world, or we're still very busy, but in a not so much COVID-19 busy way, is visibility. So I think we need to relook at how we are more visible. We and other senior colleagues are more visible in and around our hospitals. It's at a level that people expected and had in the pre-pandemic world too. I think that's going to be really important. All of that being said, they're not the only things that we are working on in the background. We also have further developments such as the temporary staffing model. The reason why I put that in further developments is because we're obviously coming into winter. We will agree the rates of pay, but bringing the two temporary staffing services together, we brought a proposal to that in our August People Committee development session. It will take a period of time to align our systems and ways of operating to making one shared temporary staffing solution, but it's very much in work in progress. And we have a number of other things, as you can see here, in terms of joint occupational health service, the appraisal process, which clearly needs to be inclusive of our values and our priorities. We need to align our statutory mandatory training. Again, these are things are very similar, but they're not consistently, you wouldn't see them as directly consistent. There's little nuances in each hospital that we need to work through. And again, as I say, make them consistent and reduce duplication. And of course, Emma wouldn't forgive me if I didn't talk about the volunteers here and our desire to be the largest volunteer base as a group in the National Health Service, and the diversity of those volunteers is going to be ever so important, and again was referenced in Debbie's presentation earlier today. So I think we got the next slide talks around, again in a summary format, in regards to how we monitor some of this at our Joint People Committee, but I don't profess to go into that in huge detail. I think in summary what I would say is the plan is there, we've launched it, we've taken some action, we've seen some outcomes to that are positive, but there is definitely more to do, and the immediate priorities of taking away some of those frustrations and barriers to collaborative work in is going to be the big focus of our attention in the next 3 months. I'm happy to take any questions, mindful of time.
Okay, thank you for that. Any questions or comments on that? I mean, I think in general, just giving people time to think, Mark, it's very important. The group has to demonstrate its benefits to the staff as a whole. At the moment, many people see it as a cost, not a benefit. And we set it up to make other things possible. So I suppose the essence of my comment is we need to move from we will to we have on a greater proportion. And that will apply right across the group functions, really. And I appreciate the effect of COVID and all of this, but nevertheless, that kind of pressure to deliver, to facilitate all the other clinical work remains very, very high. Janet.
Thank you. Some questions and a comment. Basically, is there an offer that the non-exec directors and potentially others could make to you in terms of looking at creative ways of looking at new recruitment opportunities aligned to the way that the organisations are growing? The next is, have you sought further national support and fed into the national team, Pereira, for example, in terms of any issues where potentially the workforce planning for the next 5 years may not meet our needs? And I'm wondering, Mark, if you've got a link in there. Thank you, Chair.
Thank you.
I'll come back to that, yes. So yes, in terms of the national team, I have been linking with John Drew, who's the national lead for staff engagement and health and wellbeing. Predominantly, that linkage has been caused in regards to the health survey and the success of our health and wellbeing programme in NGH. So been talking to John very openly and honestly about what we can do in those particular areas, but also from a workforce planning perspective. And of course, it was referenced again earlier with regards to theatre staff. So how, in terms of ODPs and our operating department practitioners, how we emphasise the benefits of that career. So we've been working more on what does that look like for and when you become an ODP, how do we celebrate that that opportunity of a career, and where will it end in terms of where can you go and develop into, because we know that posts like that are going to be so important moving forward as we potentially as a health service move to more surgical based interventions in a hospital, more acute based interventions, and therefore potentially some other elements being looked after in the community. So a long answer to your question, but the short answer is yes, Janet. So the first element, in terms of the sorry, it's the second element. In terms of the first element with regards to recruitment, I'm always happy to have and share and receive any ideas and suggestions in and around what we could do to further enhance our recruitment offer. I think at the moment, honestly, we haven't yet accentuated the benefits of the university hospital and what that can, the university hospitals, and what that can bring in addition to the clinical work or the work that is being undertaken, but also that benefit of research and linking with our colleagues from the university. Of course, we have Edmund now, who's joining our committee, which will be fantastic to do that as we move forward in the Joint People Committee. But I think there's definitely some work we can do in terms of, as I say, accentuating the benefits of being a university hospitals group.
Okay, any other comments at all on this? No, I think one of the areas, Mark, is that our incoming nurses, particularly our overseas nurses, always demonstrate a very, very high intent, desire to progress through practitioner grades and specialist qualifications and so on. And I think behaving as a group, we need to think very carefully. Operating assistants is fine, but theatre nurses, ITU nurses, our own training programs or training programs with Leicester, it seems to me we could probably do rather more to show that we want our staff to progress, and we're not limiting that by artificial budgets. Okay, nothing more on that. Mortality, morbidity, Rabia, please. And Manjula, who's just popped up. She's probably
yes. Thank you, Chair. Manjula, Dr. Natharajan is presenting that report, if that's okay. She's our mortality lead. She's here, so I'll just pass on to her.
Thank you for giving me this opportunity to present. I have to say, confession, if my background is the other way around, I was preparing for Teams, not for Zoom, so apologies straight away.
Okay.
Starting with the report, I'm going to assume that everybody has read the mortality annual report. Just going to give you first of all, one big headline. I think the whole of last year was overshadowed by COVID-19 pandemic, as we all know, in all walks of life in the organization. But I think especially so with the mortality group and the medical examiner group, we had about 150 more deaths than the normal year last year. That gives you an idea about the workload within the medical examiner's office. So just to start with the sheer numbers, so our mortality indicators, and I'm not going to go into detail with that, the report tells you, we always measure ourselves with HSMR, SMR, and SHIMI. HSMR was fine. Our SMR, which includes the COVID deaths, we were above expected, as were our peers and nationally. Our SHIMI, towards the end of the year, we had a slight blip, and I'm really pleased to tell you that we have come back to as expected range again. That kind of finishes our numbers. Just to give you a kind of, again, an overview, 26% of our deaths last year was due to COVID. The next bit I just want to highlight is what were our achievements. I think it was a very difficult and challenging year for the mortality review group, but more importantly for the medical examiners group. We started the medical examiner process in April last year, just in time of the start of the pandemic. And we managed to scrutinize 95% of all our COVID deaths were scrutinized by the medical examiners. And what were the benefits of this? Despite continuously changing guidelines with regards to reporting, the medical examiners and the medical examiner officers managed to scrutinize the reports, scrutinize the deaths, give the medical certification cause of death in a very timely fashion, such that the bereaved families were not left hanging. So our turnaround time for these was really, really fortunate for the bereaved families. They were then given the opportunity to talk to a medical examiner if they had concern about the quality of care of their neared ones. I think that went down really well with the bereaved families. And again, it was a great teaching experience for the junior doctors. Many trusts around us during this time, for a variety of reasons, paused the medical examiner process. For practical reasons, for pragmatic reasons, for COVID safety reasons. Our team continued to plod on, and we never paused, and we complied with all the national guidelines. I think that's a real kudos for the team. And during this time, the other thing I just want to emphasize here is we've always prided ourselves about learning, us being a learning organization. So apart from, if I remember right, apart from June, we didn't pause our trust-wide lessons learned forum. We, in fact, reinvigorated it and changed it to COVID learning and invited teams to talk about learning within their divisions and also the learning from mortality reviews. The M&Ms, the morbidity and mortality meetings, we again restarted very quickly via Teams. And so we were able to, again, use the M&M meetings to get the learning down to the divisional and the specialty levels. During this time, we also managed to win some accolades in the HHJ, a coding award, and also we were in the patient level analysis for Dr. Foster. We were in the runners-up group. And during all this period, just towards the end of the year, then we suddenly got news that we've now got to extend our ME scrutiny to community deaths. So what we've done is we've got to get ready and be ready with that process by April 2022. But what we have done in the meantime is started this as a pilot process. We managed to get a green tick from all the governance processes and all the stakeholders, including our coroners and registrars. We're ready to start. Well, in fact, we have started last week. So that's a real plus point. So I would just like to say it was a tough and challenging year. And as you would expect, KGH stood up to the challenges. And I think the team did a tremendous job. And we continue to learn and we continue to do the ME process strictly within guidance. I'm going to stop there, hand over to Rabia. I'm sure she'll have something to add.
Thank you very much, Manjula. I think you've covered everything. Just really wanted to say a big thank you to you and the team. And I think for me, it is really, really important that we were able in these difficult times to offer the assurance to the carers and the families, but also a lot of learning that came out of it, which we focused on and were able to improve and strengthen our processes. So I wouldn't add anything more to it. I'll hand it back to Chair. And
okay.
If there are any questions.
Thank you very much. I think you're right, Manjula, to talk about this. This is a good news story. Talking about deaths doesn't sound like it, but this is a good story. And I think one of the features of openness, particularly around the lessons learned approach in Kettering, for those that don't know much about other hospitals, it's really quite a remarkable process. and it doesn't exist in most places. The openness, the transparency about it, and continuing it in difficult times is something that really marks the hospital out as being something quite different. Chris, this went through your committee.
It did, and you've said everything I was going to say, Alan, except one thing. This proves not only that Kettering is a learning organisation, but also is now a teaching organisation, because Manjula and her team have been able to provide advice to other organisations on how to deliver this and the culture behind it. So it's a really positive report.
I agree with that. Any other comments at all on this? It is just a good story, really. Okay, thank you very much. I've got 10, 11, 12 items, all of which are just for approval. I'm going to assume they're approved unless anybody puts their hand up in the next 10 seconds. No, that's good. So we can approve the review to the Constitution that's finally ground its way through negotiations. We can approve the Edmund's appointment to the People Committee, but I'm sure he'll also be picking up something with the Digital Committee around some of his expertise he talked about this morning. And the Strategic Development Committee is simply extending that now to a joint committee, which will allow us to think strategically about the whole estate. And we do need to raise the quality of that debate up to a strategic one. We don't have any questions from members of the public. Is there any other business at all? Other than to say happy birthday to Polly, who I gather reaches some remarkably young age today, which I've long since forgotten.
21.
Any other comments at all? Any other business? No, thank you very much. You've lost 5 minutes. I'm not giving it back to you. We'll start again in the private meeting at 1:30. Thank you very much, everybody.